Okay, so we are going to start with chapter 27. It's just going more in depth with the cardiovascular system. That's what the next 4 chapters are. We're only going to do 2 today. And then Sunday, I have another group set up to do the other 2 that we have. And then this coming Thursday, we have our first quiz. So I'm doing a study group for the quiz for a review on Wednesday night, 4 p.m. So if you can come to that, please come. But if you come to that, make sure that you have questions ready and things that you need to review, because it's way too much information to cover everything over again before the quiz. So any questions when it comes to drugs, when it comes to clinical reasoning, when it comes to what we covered in the slides, any of it, all of it, bring it on Wednesday before the quiz.
If people need a math help as well,
Oh yeah.
I do that. So if you want help with math, I can make it easy for you. I know how to do all the math that's associated with the exams we'll get.
Okay. If you want to, we can do like a part of the study group where you can go over a few myth things if you want to do that. That works.
Questions, I got everything. It's just, yeah.
Okay, perfect. But yeah. So starting off chapter 27, I could get to. All right. So management of patients with coronary vascular disorders. Coronary atherosclerosis. Atherosclerosis is the abnormal accumulation of lipid deposits and fibrous tissues within arterial walls and lumen. In the coronary artery atherosclerosis, blockages and narrowing of coronary vessels reduce blood flow to the myocardium. Cardiovascular disease is the leading cause of death in the United States for men and women of all races and ethnic groups. And coronary artery disease, which would be CAD for the rest, is the most prevalent cardiovascular disease in adults. I don't know if you guys actually are copying the slides or not, because they are on Blackboard for you to look at. So I'm not going to stick on them super long. If you need them, they are on Blackboard, so you can copy notes, because I want to go through this as quickly as possible. This is the pathophysiology of the atherosclerosis. So A starts out clear, and then as you go down, you get the deposits of the lipids and blockages of the blood flow. So that's what they look like. Image describes about coronary arteries. So this is just like the basic coronary arteries of the heart and where you'll find them, what they're called. Clinical manifestations. Symptoms are caused by myocardial ischemia. Can anybody tell me what myocardial ischemia is? Does anybody know?
I can answer if no one else.
You can.
Isn't it when, like blood flow is obstructed?
Exactly.
Yes. Lack of blood flow, lack of blood supply to the area,
building
poor
up,
perfusion, lack of oxygen.
Yeah, because of the atherosclerosis, right?
Yep, exactly.
Of, okay, I guess we're getting into angina, but I wrote it all at once.
Yeah.
So angina, chest pain, because when not enough oxygen is getting to an area, you have pain, and this is the chest, myocardial ischemia, myocardial heart.
Yep.
That, and when there's not enough oxygen getting to the heart, it can lead to tissue death, which isn't mentioned here, which is known as myocardial infarction, which is the at the end, but that's the immediate, and this is
yes.
Yeah. And the book
So,
at the start of the chapter mentions, it just lists a flow chart that says myocardial infarction can lead to heart failure, and then sudden cardiac death. That's
yep, exactly. So the myocardial ischemia, like we said, is when blood flow to the heart is reduced, preventing the heart muscles from receiving enough oxygen. And this can lead to severe damage of myocardial tissue, which can cause low cardiac output and heart failure. Okay, so symptoms and complications are related to the location and degree of vessel obstruction. So that pretty much means the worse the obstruction, the worse the pain, the more complications you'll have. Angina pectoris is the most common manifestation. Like we said earlier, angina is chest pain. So any kind of pain, chest, going to the arms, going to the jaw, any of that is angina. Symptoms, like we said, epigastric distress, pain that radiates to the jaw or left arm, shortness of breath, atypical symptoms in women. A lot of anxiety is seen in women. So that's something to remember. Anxiety for women.
Don't women also have like one thing they have that men don't is the feeling of impending doom?
Yeah, that's the anxiety.
Feel something's coming.
Yep.
So,
Yeah, you can just consider it anxiety. That's how they're gonna bring it up.
Yeah, exactly. But yeah, it's
Yeah,
the
you-
feeling of impending doom. That's pretty much a form of anxiety. Myocardial infarction, which we all know is a heart attack, heart failure, and sudden cardiac death. Risk factors of coronary artery disease. There is a chart in your book. The 4 modifiable risk factors cited that are major is the cholesterol abnormalities, tobacco use, hypertension, and diabetes. So those are 4 things that you need to make sure that you can help your patient modify to help prevent coronary artery disease. Elevated LDLs is the primary target for cholesterol lowering medications, which we'll get into. The Framingham's risk factor calculator, that is a tool that's used to predict the likelihood of having a cardiac event in the next 10 years. So there is, I don't know the exact way that they calculate it. It's probably more complicated beyond what we need to know. But just know that it's how they calculate like the chances of having a cardiac event in the next 10 years. Metabolic syndrome. It's a cluster of conditions that increases the risk of heart disease and stroke. So I'm going to list for you these conditions that they put together. So high blood sugar is one. The next is obesity, especially fat around the midsection. The next one is dyslipidemia, dyslipidemia. And that's high triglycerides. So it's that cholesterol area. The next is hypertension, which is pretty much obvious. Okay, and then the next is the pro-inflammatory state, which is a high CRP. And so what high CRP is, it's high C-reactive proteins. And these are levels that can indicate inflammation in the arteries of the heart. And that means a higher risk for heart attack.
I have a little bit more after.
What?
I have a little bit more after if you weren't done.
Yeah, pro-inflammatory or for this in general?
Oh no, just for the metabolic syndrome.
Oh, okay, I have one more and then go for it.
Okay.
Okay, the last one is the prothrombotic state, PROTHROMBOTIC state. And that is just an increased tendency to develop blood clots. All yours, Adam. What you got?
Okay, so I just went I went straight from the book. So
Yep.
the first thing it lists for metabolic, first of all, metabolic syndrome is type 2 diabetes.
Mm-hmm.
You think metabolic syndrome, you think type 2 diabetes. So if they bring up diabetic, type 2 diabetic, even though whatever, that's metabolic syndrome. Most type 2 diabetes patients have metabolic syndrome. Insulin resistance is specifically, which is a high fasting glucose, which you mentioned, high blood sugar, but it's described as insulin resistance. And the high fat around the midsection is known as central obesity. And the waist size, the average waist size for a male and a female, so a male, I believe, is greater than 40 is centrally obese, and a waist size of greater than 35 for a female is centrally obese. So if it says, female presents with waist size of 36, they're centrally obese, sign of metabolic syndrome.
Yep.
Uh,
That's
this
in
will-
inches for women who have pant size that don't go by inches for some stupid reason.
We did, so the book is weird. It says blood pressure persistently above 130/85. That's very close to hypertension. It means hypertension. We
Yeah,
did
it's
that.
pre-hypertension.
Yeah, and prothrombotic state is specifically an increase in fibrinogen level, and fibrinogen is one of the things that causes the buildup of atherosclerosis. Think of like your artery and like a bunch of buildup of plaque. The plaque is made up of like fibrinogen and stuff, so it's like an increase in fibrinogen, which obviously would lead to let's see. We do anything else for risk factors, or
No, I think that was it.
it mentions high sensitivity C-reactive protein. We did that. HSCRP,
But yeah, that's the high sensitive C-reactive protein.
yeah, inflammatory marker.
Yep.
The higher your levels, the higher your risk for an acute coronary event, otherwise known as an acute coronary syndrome and myocardial infarction, which we'll get into, but it doesn't mention this, which is important.
Mhm.
And yes, so here's a big one. I have it under risk factors. One of the big things you're going to be doing, which we'll go into an assessment, is you're going to be taking you're going to do like cholesterol blood tests, which I forgot what it's called, right? What is it?
Cholesterol?
Whatever. Yeah,
That's not the CBC, right?
no, it's not. I forgot
Okay.
what the test is called, but you're going to test for cholesterol, and there's levels
Yeah.
here to go over. But specifically, a high LDL, which is the bad cholesterol, is the primary target for cholesterol lowering medications.
Yep.
That's the books. It bolds that under risk factors.
Yep.
High LDL levels.
Yeah. And that's something that we'll get into a little bit when we talk about just like the drugs in general, probably before the quiz that we have, we'll talk mostly about the drugs. But like when it comes to the cholesterol medication, they target the LDLs. That's pretty much where that comes from. Okay. So prevention is control cholesterol, dietary measures, physical activity, medications, stop tobacco usage, manage your hypertension, and control diabetes. These are all kind of obvious things, and these are the modifiable factors that we were talking about before. So lowering cholesterol and goes hand in hand with dietary, but that can also be a medications thing as well.
Profile.
Mhm.
That's what it is. Okay, so yeah, it's under control cholesterol. I actually have stuff that was written more from the book on that. So the book
Yeah.
mentioned the levels. So if you want to, you're going to be presented with levels. This is how the question in the exam is going to be presented to you.
Mhm.
I'm going to present you with a fasting lipid profile, which is going to have levels of LDL, total cholesterol, HDLs. Now, my levels here are from this chapter, but she actually,
I will show us, they posted a levels chart for us.
you should write that down and put it in with your notes for this, like right now. Because this is where it matters. This is where cholesterol matters.
Yeah, let me pull it up.
This is also the chapter that's associated with the atorvastatin, which isn't in the it's in the chapter, but it's not in the syllabus. So
Yeah.
put atorvastatin in with this.
Seriously.
And yeah, you're right. I didn't see that before, but metabolic syndrome is if you have 3 of the 5 things.
Yeah.
You want to know them all, though, yeah.
Yeah. All right, let me just pull up what they gave us on Blackboard for you guys to see when it comes to blood levels,
Oh,
because
yeah,
we can,
if you need, you can put it on the screen actually.
yeah, I'm gonna put it on the screen.
And yeah, so everyone who comes in presenting with like any signs and symptoms of like angina, you're always going to treat the immediate symptoms and the underlying problem, which is coronary atherosclerosis. So anyone who's age 20 and up who comes in will have a fasting lipid profile.
All right, we see this. Okay, so this is the Brunner labs that they posted for us on Blackboard. It has all the electrolytes, the bun, the creatinine, coagulation, prothrombin, the CBC level, so the hematocrit, hemoglobin, white blood cells, all that, and then cholesterol right here.
You have your height, you have your HDLs, you have your total after that, which is just mentioned as cholesterol.
Yeah, so
levels in-
HDLs is the high density. Do they not have, oh, there it is, low density. So the LDLs, these are the bad ones that we have to pay attention to. So these are the levels for that. And then triglycerides we'll also be talking about too. Those are the levels. So all of the levels that we need are on this page, which is all on Blackboard. So use this to your advantage. Anything else on the levels?
That's all. Yeah,
Okay.
just like the levels. Yeah, I wrote something that doesn't need to be here, so yeah.
Okay. All right. Okay. So cholesterol medications, there are 6 types of lipid lowering agents. They affect the lipid components somewhat differently. There's a table for it in the textbook that you should take a look at. And then these are all of the things, or not, we didn't learn about all of them, but we learned about a couple of them in 115 last semester. So we have our HMG COAs, which are statins. There are nicotinic acids, the fibrates, which is fibric acids, bile acids, sequestriants or resins, cholesterol absorption inhibitors, and the omega-3 acid ethyl esters. It's like freaking gibberish, man.
Yeah, there's a chart's pretty good. I printed it.
Yeah, the chart is helpful. So
niacin is also a drug that she
Mhm.
mentioned in class.
yeah,
That she didn't mention here. I have it as a drug card because we used to do a chapter associated with it.
okay, we didn't do that last
Here
semester.
we don't. So you guys probably won't get it. But I wrote it down, just whatever. Just
Okay.
the name niacin.
Yeah,
So yeah, the drugs associated. that
that's
we've got-
probably the nicotine acid niacin.
yes. Atorvastatin and fenofibrate are
Yeah.
the drugs that we have.
Yeah. Probably, yeah. Atorvastatin is one of the biggest ones to remember. It was also big the last semester. So just make sure that you go over the atorvastatin.
Yeah, these other ones we didn't do.
Okay, question.
I have a
The
little
ner-
bit more.
Oh, sorry, I'll go back.
No, not about the drugs. There's stuff before the drugs that the book mentions. The slides kind of skip over
Yeah, I know.
like dietary measures and physical activity for some reason. So
Yeah,
dietary measures, these are nursing interventions. Straight up, these are nursing interventions for prevention of
yeah,
coronary
I went
artery
back
disease.
again.
Yeah, okay, yeah, that's fine. I didn't realize it just lists it without explaining it.
Yeah, it just lists everything.
Dietary measures includes a TLC diet. TLC is therapeutic lifestyle changes. So you're put under a TLC diet. That's all. It's a diet that is, so first of all, any diet that is prophylactic for a heart condition, such as angina and thus underlying coronary atherosclerosis, or someone who has an MI, what you're going to be teaching after the MI, which is something we're going to obviously be tested on, is the patient teaching post MI. Is you're going to be teaching on, you're going to want to know the nursing interventions for the teaching. So dietary measures, they'll be placed on a TLC diet, which is a therapeutic lifestyle change diet, which is a diet that is low in saturated fat and high in soluble fiber. And she mentioned it in class as well.
Mhm.
Diet low in fat, high in fiber.
Yeah.
You also want to decrease, thus because of that, you want to decrease your consumption of red meat, which I believe was gone over at one point. And if you can be a vegetarian, it's the best possible thing for you. If you have an MI or if you have a coronary atherosclerosis, lesions of coronary atherosclerotic lesions is what I'm trying to say.
Yeah.
Decrease in red meat, go as vegetarian as you can. It's just good for the heart.
Yeah.
And then
Lowest fat possible.
Yes. And then we have physical activity. So your triglycerides, prior to medication, kind of like hypertension, you would do lifestyle changes, unless it's like abnormally high. Physical activity, the book lists, if you have an increased triglyceride level, it can be managed with weight loss and physical activity. And weight loss and physical activity also increases HDL levels. So it lowers triglycerides and it increases HDL levels.
Yep.
And okay, here's the important stuff. Moderate aerobic activity is what you would recommend to a patient as physical activity. Moderate aerobic activity, which is like brisk walking, 150 minutes per week, vigorous aerobic activity, running 75 minutes per week, muscle strengthening exercises, so like lifting or like squeezing like a thing, whatever, 2+ days per week, and stop if you're experiencing chest pains and shortness of breath. And that's pretty much that. And she went over a couple of them in class as well, but that's all of it.
Yep. So it's pretty much your basic diet advice. It's lower fats, increase fiber, and exercise properly.
LDL is lowered. LDL isn't lowered by anything but medication. So if
Yes.
you have a high LDL, the only thing you can do to lower it is medications and decreasing the consumption of bad fat
Yes.
and
Exactly.
like saturated fat and stuff.
Yeah.
So if LDLs are high, it's different than your triglycerides being high. You can have everything, but the two specific things that are affected by physical activity are triglycerides being high,
Mhm.
weight loss, and physical activity lowers that, and HDL levels being low can be increased with physical activity in general. LDL
Exactly.
needs medical attention.
Yep. Exactly.
Medication.
Okay. Awesome. But yeah, I mean, the best advice that I can give you guys so far with what I've experienced for the semester is that big things that we always have to be thinking about is like nurse teaching and things that you're going to be doing for your patient, because that's our job. It's not necessarily to know the ins and outs of all of these diseases that we're going through. It's to know what the signs are. It's to know what the symptoms are. It's to know what to look for, and it's to know what you're teaching your patient. So it's the things that it's your interaction with the patient. That's really everything that you need to know. So you don't need to know everything about the anatomy. You don't need to know everything about all of this stuff, but you need to know the very basics, and you need to know what to look for, what the levels are, how to prevent it. And a lot of these diseases that we're covering right now, when it comes to cardio, you need to prevent it. You can't just treat it, because once it's there, it's hard to treat, but preventing it is easy. So preventative measures are very important to know when it comes to cardio. Okay, so we went over the medications. Question: the nurse is caring for a patient with hypercholesterolemia, high cholesterol, who has been prescribed atorvastatin, also Lipitor. What serum levels should you be monitoring in this patient? You got CBC, blood cultures, sodium and potassium, or liver enzymes. Somebody other than Adam.
Sorry, they got it right in the chat already. That's drug specific.
Oh, I can't see the chat.
Yeah, liver.
Yeah.
Battle
Exactly. Liver enzymes, great. Liver enzymes. Atorvastatin is an HMG CoA reductase inhibitor and is hepatotoxic. Therefore, liver enzymes should be monitored in patients taking this medication. Why do we monitor liver enzymes? What are we trying to prevent?
It says there, liver toxicity.
Yeah, exactly. You want to prevent toxicity. Okay. Angina pectoris. You got a syndrome characterized by episodes of paroxysmal pain or pressure in the anterior chest caused by insufficient coronary blood flow. Physical exertion or emotional stress increases myocardial oxygen demand, and the coronary vessels are unable to supply sufficient blood flow to meet the oxygen demands. There are different types of angina in the chart in your textbook. Any of the charts mentioned in the slides, definitely take a look at. So pretty much angina, like we said a bunch of times earlier, is just chest pain. So this is caused because there's not sufficient blood flow, which means there's not sufficient oxygen, which can cause damage to the tissue, which can cause heart failure. So this is something that needs to be monitored and also properly treated. Assessment and findings. It may be described as tightness, choking, or a heavy sensation. It is frequently retrosternal and may radiate to the neck, jaw, shoulders, back, or arms, usually the left arm. Anxiety is frequently accompanies the pain. So it's that feeling of impending doom. That's the anxiety. Other symptoms may occur like dyspnea or shortness of breath, dizziness, nausea, and vomiting. Pain typical of angina subsides with rest or NTG, which is nitroglycerin. Unstable angina is characterized by increased frequency and severity and is not relieved by rest or nitroglycerin. This requires medical intervention. So this is all just what you're going to see when you're assessing a patient, that you're going to come in and they're going to say, I have tightness in my chest. I have pain in my neck and jaw. I have pain going down my arm. I feel anxious, or I feel dizzy. I can't catch my breath. I'm nauseous. These are all the things that people are going to come in and say to you. And one of the biggest things that's important is that it's pain that gets better with rest. Those are things that are important to know. That's a big sign for a lot of cardiac issues. Pain that gets better with rest. And then unstable obviously doesn't get better and needs to be handled immediately.
It's an MI. Yeah, unstable angina is usually ACS MI.
Yep.
That's the correlation.
Angina is usually because of a heart attack. Not always, but usually.
Unstable, yeah.
Yep. Okay. So considerations when you're dealing with older clientele is that they have diminished pain transition that occurs with aging, and it may affect the presentation of symptoms. It can be called a silent CAD. So you have to teach your older patients to recognize their chest pain-like symptoms, including weakness. So they're not going to feel that stabbing pain in their chest, their pain in their jaw or neck or arm or wherever it is. That's not what they're going to feel, because of how their pain transition has changed with age. So they're going to have weakness. They're going to have issues with the breathing. They're going to have sometimes numbness, I believe. They're just different side effects that need to be recognized as similar or equivalent to the angina pains when you see in younger adults. Pharmacological stress testing and cardiac catheterization. Who can tell me what cardiac catheterization is? We did this last study group, so you better remember.
Just a quick add-on to before.
What?
Does it mention here? Oh, it doesn't mention it. It just says meds should be used cautiously.
Yes.
The medications to treat angina, nitroglycerin, the main one, is Beer's criteria. So gerontologic.
Yeah. Yeah, that's another thing that we always have to be cautious of is the Beer's criteria. Anything that can't be used or should be cautiously used in the older adult patients. So nitroglycerin is one of them. So it's something that needs to either be monitored very closely or something that needs to have an alternative. Okay, so back to my question. Who can tell me what a cardiac catheterization is? We did this last study group. You should know this. Come on, guys. Anybody? It's okay to be wrong.
I can.
No.
Yeah. No.
Inserting a catheter into the blood vessels, right?
Exactly. Thank
Artery,
you. That
artery,
was
yeah.
Arda, right?
Yeah, but I have a question because I get confused on this a lot, and I wasn't
Yeah.
here last time. So does it go through where it goes through the groin all the way
Yep.
up, correct?
Yes.
Okay.
Femoral artery, usually up
Mhm.
to, it can go into the radial, but it's usually in the femoral, all the way up until, what is it, the aorta?
Yeah.
Yeah, the aorta. So it always goes through an artery.
Yep. Yeah, it's the insertion of a catheter into the artery. They can take tissue samples, and sometimes they put in dye to see how well your blood is flowing. It's to see if there's any kind of damage, if there's any blockages, any kind of cardiac issues going on.
And
Cardiac
if there is
catheterization.
something, if there is something, cardiac catheter is very important, especially this chapter, because if they go in with a cardiac cath and they see something and it needs immediate attention, they can, there
Use
are
the
things
cardiac
they can
cath.
do. Yes, and that is in this chapter, and it's very important because she's mentioned it. I don't know, in class she mentioned it. It's a
Yeah,
whole
that was the
section.
last class. So we're gonna come
Another
back to it
portion
next.
of cardiac cath, so you need to know what cardiac cath is.
Yes,
That's
And
why
it's-
I asked.
she keeps
Yeah,
mentioning
no,
scans
all
too,
encompassing cardiac cath.
and MRA scans. Like she ever since we started this, like anything cardiovascular, she keeps mentioning scans. So I feel like that's gonna be really heavy on this quiz. Probably there gonna be a few questions on that.
Yeah, I think that what's important to know is the types of scans and the patient teaching that is accompanied with it, which I drilled the last time, and it's in the video on YouTube that I post every time we do a study group. So know the patient teaching for those scans, know about cardiac catheterization, and we're also gonna probably need to know a lot about the drugs. So those are the biggest things to make sure you study. Other than everything, but it's not a lot of information, right, guys?
Just be aware that a cardiac cath isn't considered a scan. It's invasive.
No,
It's,
that's an invasive procedure, a cardiac
they,
cath.
it's general anesthesia. It's the, other than a coronary artery bypass graft, which is the last thing you're going to be doing as an intervention for cardiac patient. This is the main definitive diagnostic, and it can also be an intervention. So cardiac cath is the main thing in cardiac. It's going to be on the exam 100 times.
Which is why I asked somebody to tell me what it was, because it's important to know. And also when the cardiac cath, just remember that, like Adam was saying, it's not just a test. If there is an issue, they can also use it as a treatment as well. They're there. So it's very important because it can also be a treatment method. Okay, moving on. Treatments. Treatment seeks to decrease myocardial oxygen demands and increase oxygen supply. You have medications, oxygen usage, so being on like oxygen at home, reducing control risk factors, which we were talking about before, includes like the amount of exercise, the amount of fat you eat, your diet, everything like that. Reperfusion therapy may also be done. Anything to add to this one, Adam?
Reperfusion therapy is what we're going to be getting into next. I don't know if I mentioned it again. Reperfusion therapy is known as I believe it's PCI, and yeah, it's the PCI. It's what happens when you go in with a coronary, when you go in with a cardiac cath, and they put like a stent in, or they put the balloon thing in. I forgot what it's called. It mentions it. That's reperfusion therapy. That's what that is. Also, I believe CABG coronary artery bypass graft is also considered reperfusion therapy. It's just therapy. It's a procedure that reperfuses the area.
It opens it back up.
Oxygen is getting through, blood's getting through. That's reperfusion.
Yep. So like Adam said, what they do is they go in and they put in this balloon and they inflate it. It opens up the artery, and then they stent it. They put in this little piece of sometimes plastic, sometimes metal, it depends. They put it into the artery to keep it open and to help flow of blood and oxygen. So that's what that is. That's the process behind it.
I have one more thing about diagnostics. The book lists every diagnostic that's going to be done to a patient who's presenting with angina. And that is, we've gone over one, which was what was it? Cardiac cath.
Yeah.
There's also EKG, which is used during cardiac cath, so it's there. Biomarker testing, it's important. I don't know if it brings it up again, but biomarker testing is important. So if you want to put like,
We did that last study group.
yes, that's part of all the assessments. Biomarker testing, stress test, that's what you would do for an angina. And whether it be stress test, physical, or pharmacologic, which is gerontologic.
Which is also, we went over in detail in last study group, so go back and watch about those.
This is just like putting a face to the name, like what it's used for.
Yep.
Cardiac cath we mentioned, and coronary angiography, which is the angiography. I know it's a physical thing.
Yeah, I think it's an imaging of the area.
Okay, well, it's just coronary angiography, and that's
Well, ography is usually imaging.
Yes. Angie, it's gonna bother me, so I'll look at it. while we
Okay,
do.
you can look it up.
Yeah.
All right.
That
moving on.
one is to like show where is the poor perfusion area. So it's a
Okay.
contrast.
There you go. Those are all of the things that all of the diagnostics the book lists for angina and thus coronary atherosclerosis.
Yep, perfect. All right, medications. We got nitroglycerin, the beta adrenergic blocking agents, the calcium channel blocking agents, antiplatelet and anticoagulant medications, aspirin, which is an NSAID, which is we all have learned that you'll worry about bleeding. The clopidogrel and the ticlopid. We didn't do that last semester.
Oh, I can do the prototypes if you want, so people can so they can which ones that the book specifically mentions the prototypes that we've gone over.
Mhm.
So it's atenolol. It doesn't mention propranolol. So atenolol,
Okay.
diltiazem, and amiodarone. I have those. I don't. Or amiodarone. I don't know if you guys have
We don't have amiodarone.
Okay, I have diltiazem, amiodarone, aspirin, and clopidogrel, both listed.
Yeah.
Heparin and enoxaparin.
Yep.
Not warfarin, because this is specifically something that's treated in the hospital, and warfarin isn't used in the hospital.
Nope.
And this glycoprotein thing, we
Mhm.
don't. It lists something, we don't have that. But something that's important for the glycoprotein thing, it's only for hospitalized patients with unstable angina. The book bolds it.
Okay.
So it's specifically used for hospitalized patients with unstable angina, like very bad angina.
Okay. So the heparin and the glycoprotein are both things that we only use in the hospital because they're IV. Slash.
Okay, yeah,
Oh.
amiodarone is there.
Yeah.
And diltiazem should be there as well, because I have that. Okay.
Okay.
So I attribute that to this chapter and this subject. So all of the drugs that we've gone over thus far, we went over atorvastatin
Mhm.
and those are all the drugs that are associated with this chapter thus far. So you want to attribute those to this chapter and study those specifically when studying this chapter.
Okay. Yeah. Yeah. Okay. You guys are saying in the chat, and the amiodarone is for the thyroid hormones. Yeah. Some of these, you'll see a lot of these reused in multiple chapters just because they're medications that have multiple uses. Something that you'll learn is that not every medication is used strictly for what it was created for. For example, the propranolol is for heart diseases. I take it for anxiety. I also take what is it called? I take a medication that's for nerve pain, but I use it for anxiety. There are a lot of multiple uses for drugs, and you'll learn that as you
I
go.
have amiodarone. I didn't realize next to it I have written just do diltiazem. So just do diltiazem.
Mhm.
Yeah, that's the
Okay.
one you should focus on.
Next, question 2. The nurse is caring for a patient who has severe chest pain after working outside on a hot day and is brought to the emergency center. The nurse administers nitroglycerin to help alleviate chest pain. What side effects should concern the patient the most? Dry mucous membrane, heart rate of 88 beats per minute, blood pressure 86/58, or complaints of headache? Anybody want to take this question?
Yeah, I mean this one's dumb. It's just the number is too low for it to be anything.
Yeah.
They said it in the chat.
Okay.
Yeah, they shouldn't have made it that low.
See, yeah, exactly.
I mean, in nitroglycerin, you just know low.
Blood pressure is way too low. It dilates the vessels in the body. Dilation of the veins cause venous pooling of blood throughout the body. As a result, less blood returns to the heart and fills pressure preload to reduce. If the patient is hypovolemic, the decrease in filling pressure can cause a significant decrease in cardiac output and blood pressure. Pretty much obvious. Okay, nursing process. Care of patients with angina pectoris, assessment, symptoms and activities, especially those that start and whatever you're doing before the attack starts, pretty much. Risk factors, lifestyle and health promotion activities, patient and family knowledge, and adherence to the plan of care. So if you put somebody on a drug and they're not taking that drug, they're not adhering to your plan of care, which is very common in patients, not necessarily because they want to necessarily, but you can have issues when it comes to your insurance policies not covering certain drugs, or they change the drugs that they cover, so you can't take it anymore. When it comes to healthcare, a lot of it is influenced by the amount of money, which is not how it should be, but it is. So some people can't afford to take their medication. Some people can't afford to eat healthy. Some people can't afford to have procedures that they need done or go to their doctors when they should. It's just how it is. Anything to add to this, Adam?
This is assessment. Let me look.
Yeah.
Here's the treatment of the patient response to angina and family's understanding of diagnosis. Risk factors for coronary artery disease. All this. Symptoms and activities such as preceding and precipitating attacks. Is that here? Precade and precipitate attacks. Yes. Oh, yeah. This is... When we get to interventions, I have a lot.
Okay. But yeah, so these are pretty much, and when it says patient and family knowledge, it's just making sure that you educate your patient about what exactly it is that their medical issue is and how they can fix it. So they need to know what the risk factors are. We'll go more into something similar to this when we talk about hypertension, because that's something that is all about prevention, not necessarily about treatment. So you need to teach your patients a lot to prevent serious illness. Okay. Risk for decreased cardiac tissue perfusion, anxiety related to cardiac symptoms and possible death, deficient knowledge about the underlying diseases and methods to avoid complications, and noncompliance, which is ineffective management of therapeutic regimen related to failure to accept necessary lifestyle changes. So this just kind of takes the last slide and goes into more detail. Okay, collateral problem number 1. So you have ACS. Adam, do you know what ACS is?
It comes up, acute coronary
Okay.
syndrome. It's the precursor to an MI.
Okay, so myocardial infarction or both, dysrhythmias and cardiac arrest, heart failure, and then cardiogenetic shock. Okay, nurse process, care of a patient with angina pectoris planning. So the goals is to immediate and appropriate treatment of the angina, prevention of the angina, to reduce anxiety, awareness of the disease process, so understanding how it progresses from wherever they are, understanding of prescribed care and adherence to the self-care program, and absence of complications. So these are just the goals that you are looking at when you're treating a patient with angina. Interventions: treat angina, reduce anxiety, prevent pain, educate patients about self-care and continued care. You said you had stuff for intervention, Adam?
Yeah, go to the next slide really quick.
Yeah.
I just want to see what it says. Okay, this is, I have this, but expanded upon, and this is what matters.
Go for it.
So this is a patient who is presenting with angina in the hospital. If patient is reporting pain or cardiac ischemia or cardiac ischemic symptoms, the nurse takes immediate action. This is straight from the book. The patient is to stop all activity and sit or rest in the bed, semi-Fowler's position. It's there. This is in order to decrease oxygen requirements of the heart, so you can meet that homeostasis again, because that's the whole point of angina. There's not enough. The heart is working hard to the point where it's not meeting oxygen demands. So this equalizes that a bit. Obviously, unstable angina, this would not solve that because it's rest. And then you're asking questions. Is the angina similar to previous attacks? Because if it's worse, that's a different story. Assess their vital signs, observe symptoms of respiratory distress and pain. If things are worse, if they're having trouble breathing, like significantly, you can give them oxygen therapy of 2 liters per minute. If hospitalized, they're given a 12-lead EKG. A 12-lead EKG is obtained, and you're monitoring for ST and T wave changes. That's ST elevation and T wave inversion. They might not ask that specific, but she
I
did
really
bring
need to
it
know
in
the
class.
specifics.
She brought this up in
Yes.
class, which is why I'm mentioning it here, and it was listed.
Yeah. Well,
These mean
she
heart
went into
attack.
detail of it when we were just learning about like the EKGs in general, but I
This
don't think
means it's a heart attack. We might be given
a graph to look at, but we don't have to
Yeah.
know how to read it necessarily. We just need to
Not
know what
count.
looks wrong.
ST depression. Yes, me mentioned ST depression and elevation. This just means heart attack. This means this person is having an MI. And ST elevation MI is the worst kind of MI. It's called a STEMI, but we actually do get into that actually. Meds given based on protocol. Administer oxygen at 2 liters per minute via nasal cannula if respiratory rate is increased or oxygen or pulse ox is decreased, obviously. And that's it. That's the book in total for this. That's Angela.
Perfect. Yep. Awesome. Okay.
Okay, wait. Actually, I have a definitive list of signs and symptoms, and I made this specifically because the book spreads them out throughout the entire section.
Mhm.
If you want to write down the direct signs and symptoms of angina, I can do that. I have it here.
Okay.
Indigestion, nausea, choking, heaviness in the chest, weakness, which is the gerontologic, numbness in the upper extremities, specifically the left, dyspnea, dizziness. That's the definitive.
Perfect.
That's all.
Yeah. All right. To reduce anxiety, we're going to use a calm manner, stress reduction techniques such as like breathing patterns and things like that. Trying like meditation of some kind, anything like that is like stress reduction techniques. Patient teaching, addressing the patient's spiritual needs may assist in anxiety relieving, and then address both the patient's and family's needs. When it comes to patient teaching, it's like where they're at in their disease, what's going to happen, what they need to do, just making them aware of the situation, because the more you know about your situation, sometimes the less scary it seems. Because we know what these things are, they probably don't. So telling them how bad what they're dealing with is can sometimes help alleviate anxieties. Okay, preventing pain. We're going to identify level of activity that causes patients prodromal signs and symptoms. We're going to plan activities accordingly. So we're going to avoid levels of activity that cause severe pain. Alternate activities with rest periods, and then teaching patients and families. So you're going to teach them, monitor how much activity you can get or for how long you can do it before you start having pain. When you start having your signs and symptoms, you need to rest. So doing an alternation of activity and rest will help prevent the pain rather than just doing the entire activity. If you can't do that, you don't do it. Pretty simple.
Yeah, alternating activities with rest period. I'm not in Me's class anymore, but she used to drive that home a lot. That's a big intervention. You want to teach them to alternate activities with the rest periods. I've seen that on an exam. I don't remember which exam. But.
Awesome. Sorry. Okay. Intervention, patient teaching. Balance activities with rest. Follow prescribed exercise regimen. Avoid exercising to extreme temperatures. Use resources for emotional support, so counseling. Avoid over-the-counter medications that may increase heart rate or blood pressure before consulting with healthcare provider. So a lot of medications do alter other things in the body. Like we said, they're not always used for what they're supposed to be used for. So when you're taking medications, you need to make sure that they don't increase the heart rate or blood pressure if you have somebody who's dealing with angina and issues with their cardiac system. So obviously they should always consult with their physician before adding anything on top of the medications they're already on. Stop using tobacco products because nicotine increases heart rate and blood pressure, as well as the fact that it's a vasodilator. So it prevents blood flow. Diet low in fat and high in fiber. Medication teaching, carrying the nitroglycerin at all times because
Write
you
that
take,
on the drug card.
yep. Nitroglycerin is something that you take on onset. It's not something you take to on a daily to manage. It's something you take as a needed onset of symptoms. Follow up with the healthcare providers, report increase in signs and symptoms to the provider, and maintain a normal blood pressure and blood glucose level.
I have one more thing.
Yep.
To do. You could use Mediterranean diet too. There's a lot of
Yeah.
diet you can use. Anything low in fat, high in fiber.
Yep.
The book just defines that as a TLC diet.
Mhm.
One of the things the book mentions for patient teaching is any pain that is unrelieved within 15 minutes by usual methods, including nitroglycerin. You can say that's unstable angina. You need to call 911. That's an emergency.
Yep.
So if within 15 minutes, like someone someone claims they had pain, unrelieved pain for 15 minutes, no matter
Yep.
what they did in
Yep.
an exam form. Balance
Okay.
activity, rest. We did that. If you're to exercise, man. Avoid extreme temperatures. So especially with exercising.
Yep. You don't want to
Extreme
get too
temperatures
hot.
includes. What do you mean call 911 with the second dose? Do you just mean nitroglycerin? Yeah,
Oh, with-
nitroglycerin has its own.
It's
has
not
its own-
second dose.
it's
Nitroglycerin has a
third, it's after
rule.
the third.
Yep.
There's 5 milligrams per, and then the total is 15. And after 15, you don't feel good. You don't feel well.
Call
You do
911.
that. The book specifies 15 minutes for some reason, so I wrote it down.
That's because you can take one of them every 5 minutes up to 3 times.
There you go.
I was going to ask that as a question, but no,
It's
I
okay.
covered it.
You put 2 and 2 together.
Yeah.
So the avoid extreme temperatures thing, that's extreme heat and extreme cold. One of the main onsets for, I should have mentioned it before, one of the main onsets for angina is cold temperatures.
Yep. Why? Anybody can tell me?
Oh, no, it's definitely not 1 dose.
No,
do
it's-
not. Yeah, no, yeah, do not do that. Yeah, look at the chapter again. It says it. The Abrams. Yeah, that's very important.
Yeah, the nitroglycerin is after 3 doses. You do 5, 5, 5. If it's not relieved, then you go and call 911.
Yeah. So for angina, one of the, let me just make sure I'm right. Okay, yes, one of the associated factors with angina, one of the onsets of angina, things that will lead to it,
Yeah.
is obviously physical exertion and stress. Eating a heavy meal can also lead to angina, because when you eat a heavy meal,
Increases
someone-
the amount of blood needed to your digestive system, increase
the
the
amount of work your heart needs to do.
Yep.
So you can be thrown off once again, where your heart's not getting enough oxygen to the increased demand. And yes. And the third thing is exposure to cold. Cold is vasoconstriction. It's the same thing as tobacco.
Yep.
Tobacco is extreme vasoconstriction, increases blood pressure, sets off your oxygen demand in your heart. Same exact situation. So it's extreme cold, and extreme heat is obviously extreme vasodilation, but no cold weather can trigger angina easily.
Yep. Yeah, cold weather leads to vasoconstriction, which leads to a decrease in the amount of blood that's traveling through your body. We'll also touch on that when we go through vascular disorders on Sunday, because that affects the amount of blood that's getting to your extremities, which is what we cover on Sunday. But know that cold is vasoconstrictive as well as tobacco and nicotine. Okay. So acute coronary syndrome, ACS, and myocardial infarction. Emergent situations, characterized by an acute onset of myocardial ischemia that results in myocardial death or a myocardial infarction. If definitive interventions do not occur promptly. Although the term coronary occlusion, heart attack, and MI are used synonymously, they prefer terms MI, myocardial infarction. But yeah, heart attack is what that is. Anything on this, Adam, or no?
So it's considered a precursor to an MI because it's considered myocardial ischemia as opposed to infarction. I don't know what exams look like now in this class, but
Yeah.
it's just, precursor to a heart attack, myocardial ischemia, and MI is myocardial infarction, which is tissue death. Ischemia is the oxygen not getting there in the first place. Can lead to MI infarction if not dealt with promptly. Coronary occlusion, heart attack, MI are the same. Okay, yes. Just running through my thing really quick. Okay, yeah, you can go next.
Okay. Effects of ischemia, injury, and infarction on an ECG. This is what Adam was talking about, the ST area. You can see in these little diagrams, there's the T, the QRT, and there's also S.
I could go into it a little bit more. I could make it really easy.
Go for it.
Brought up at all, I can make it easy.
Go for it.
So the spectrum of ACS, you have, let me just see what I wrote on the side here. Okay, so these are definitions. You have unstable, these are the different types of ACS leading into MI. These are different types of MIs. You have the unstable unstable angina, which is a precursor. You have an NSTEMI. NSTEMI and STEMI are guaranteed heart attacks. Unstable angina is like a sign of ACS, which is leading to a heart attack. An NSTEMI is a non-ST elevation MI. So there's no ST elevation, but you're having an MI, and we'll go into that a little bit more. So an NSTEMI, which I said is a ST elevation myocardial infarction, otherwise known as a heart attack, is when there's no EKG evidence, but you have biomarkers. And biomarkers is something we've gone over multiple times. I'm going to try and go off memory for my own studying here. Biomarkers are myoglobin, CK&B are the two main ones, and the other one doesn't even matter. It's troponin. Yeah, troponin. Those are the biomarkers. So if you have biomarkers, but you don't have any EKG signs of anything, which is ST elevation, that's an NSTEMI, slow heart attack. A STEMI is the worst kind of heart attack. It is an EKG evidence of an acute MI, which is an ST elevation in two contiguous leads. You don't have to know what a contiguous lead is, but the definition is important because the book brings it up 1,000,001 times, and she's mentioned this in class as well. An elevation in ST segment in two contiguous leads is a severe MI known as a STEMI, ST elevation MI. That's it. That's the whole thing. Unstable angina is defined by the book as clinical manifestations of ischemia with no diagnostic findings. And there's not going to be any diagnostic findings because you don't yet have an MI. That's it. This is how the book describes this whole thing. And so the diagnostic of an MI is, the main diagnostic of an MI, cardiac biomarkers and EKG. That's it.
Who can tell me how many times you check the biomarkers in blood tests?
I forgot that too. I know it, but I forgot that was a thing.
Mm-hmm. Do you just test it once? Somebody comes into the hospital, they're having chest pains. You need to see if they had a heart attack. How many times do you check their blood for biomarkers?
3 times.
Thank
That's
you,
right.
Bun.
I don't know at what interval though. 6 hours?
I
3?
forgot
I don't know the-
interval as well. Just know you check it 3 times. You check it 3 times
Yeah,
because
you check it multiple
an MI
times.
is progressive. An MI is progressive, so you might not have cardiobiomarkers the second time, but you might
Exactly.
have it the third time.
Yep. Who can tell me why EKGs or ECGs are not always reliable? How long do you usually do an ECG for? Basic ECGs, how long are they? A minute max. Does that tell you much? If your patient had a heart attack, are you going to see that on the ECG an hour after? No,
An hour after they've been, but an
you're not going to
EKG
see it on the ECG though.
Yeah, an
You'll
EKG
just-
hookup. You can hook up an EKG if you're hospitalized. You
Yes,
can have a 12 lead on you for a long time.
yes, you can. But a standard ECG, minute long. It's just a snapshot of what's going on. It does not show you everything that's going on or has gone on. So those aren't always reliable right away. More reliable, like Adam was saying, is the 12 lead. You hook somebody up, they're on that until you take them off of it. They're attached to a monitor. So you see that ECG constantly. That's reliable.
12 lead is cardiac. Almost everything, including the interventions, involves a 12 lead.
Yep. 12
That
lead is the way to go. And
I
that's how you'll see the ST wave, is when you're doing long-term ECGs. But biomarkers are definitely an easier intervention because it's something that, yes, you have to test multiple times because it's a progressive and it takes your body time to release those biomarkers after you're having the myocardial infarction. But if you had that, those biomarkers, they're going to tell you definitely happened when it comes to
or having one. Yeah.
no, what I'm saying is that like if you see those biomarkers, that's done. They had that MI, but you're not guaranteed to see them on the CTs. Sorry, the ECGs.
And once again, remember that biomarkers are CK, CKMB, troponin, and myoglobin.
Yep.
CK
Know
and
those.
CKMB is what she specifically said to remember, but the other two are easy to remember as well. Doesn't matter.
Yep. All this is very important to remember, guys. Okay. Caring for a patient. So, chest pain, it occurs suddenly and continues despite rest and medication. Other signs and symptoms is shortness of breath, CO ingestion. Any idea what that is?
What does it say?
CO indigestion.
Cardiac output, right?
Maybe.
Why does it say indigestion with that?
It might just be a sign and symptom.
Sign.
So
I
it
have
might-
shortness of breath, dyspnea, syncope, unusual fatigue, which I think is what that is.
Okay.
But the book specifically says unusual fatigue.
Okay.
as a thing.
Yeah. So nausea, anxiety, cool, pale skin, increased heart rate, respiratory rate, and then fatigue. So then you
this-
have,
Is it CO complaint of?
maybe complaint of indigestion. That could be. They use too many friggin' abbreviations.
No, you're right. It complains of. I completely forgot the abbreviation because I've been doing cardiac chapters this whole time. So I think cardiac output, COE/O is complains of. CO is cardiac output.
Okay, makes sense. Okay. Okay, so then you have the ECG changes, which is the elevation of the ST segment in two continuous leads, is a key diagnostic indicator for MI. And then you have lab studies, which is the cardiac enzymes, which is the troponin, the creatine kinesis, and the myoglobin. Diagnoses. You have acute pain related to increased myocardial oxygen demand and decreased myocardial oxygen supply. Just means you have pain because you're trying too hard to get oxygen you don't have enough of. Then you have risk for decreased cardiac tissue perfusion related to reduced coronary blood flow. So
All poor perfusion.
what?
All of them are poor perfusion.
Yeah. You have risk for imbalanced fluid volume, a risk for ineffective peripheral tissue perfusion, anxiety related to cardiac events and possible death, and deficient knowledge about post-ACS self-care. Collaborative problems. You have acute pulmonary edema, heart failure, cardiogenetic shock, dysrhythmias and cardiac arrest, and pericardial infusion and cardiac tamponade. So these are just problems that go hand in hand with the issues that we're talking about now. Okay. So now we have planning. You have goals. You want to relieve the pain or ischemia signs, so the ST segment changes, and symptoms. You want to prevent myocardial damage, maintenance of effective respiratory function, in adequate tissue perfusion, a reduction of anxiety, and adherence to self-care program, and early recognition of complications. So these are all of the things that you are aiming to do when treating your patients. Nursing interventions is relieve pain and signs and symptoms of ischemia, improve respiratory function, promote adequate tissue perfusion, reduce anxiety, monitor and manage potential complications, educate patients and family, and provide continuing care.
Can add a little bit.
Yeah.
So nursing 120 is clinical reasoning, right? So you're going to be presented with something and you need to you have to answer the question in the form of a nurse. And most of the time that's interventions, stuff like that. So you want to write down nursing interventions when you can. If there's a list of 1 million of them, write down the unique ones.
Mhm.
So improve respiratory function here. The book specifically mentions breathe deeply and change position frequently, which is a lot of things to improve respiratory function, but it lists it specifically. Monitor pulse ox and fluid volume status, intake and output, and 2 liter per minute oxygen via nasal cannula if needed. Once again, that's improved respiratory function.
Yeah.
Okay, what else do I have? Promote adequate tissue perfusion. I have bed or chair rest will decrease the myocardial oxygen demand. So that's something you can tell them. You can tell them to rest in the bed or chair. You want to also monitor their skin temperature and peripheral pulses for promoting adequate tissue perfusion. You're assessing. So
Yep.
Decrease anxiety, honest and frequent questions, be honest with their questions, ensure that there's a quiet environment, stuff like that.
Yep.
And and the last one is educate patient and family and providing continuous care.
Yeah, perfect. Like Adam said, when you're answering these questions and looking at these tests and quizzes, you have to do it in the eyes of being the nurse. So you're looking at these questions where it gives you the symptoms of the patient, or it's asking you, what are you going to do with this patient? Well, you have to remember what's the job. The job of a nurse isn't just to give meds and to change wound bandages and stuff. We're teaching our patients how to take care of themselves when they leave. So you need to make sure that you educate them. So you need to know what it is that you need to do to help them in the process of not just being in the hospital, but what to do after the hospital.
We'll get into it more in heart failure, but preventing rehospitalization is the main thing.
Yep. Which is, we had covered a little bit last time, preventing rehospitalization because that's the most common thing to happen. But can you guys remember why most people with heart failure return to the hospital? What are the signs? What are the symptoms that they're having that makes them go to the hospital again? What goes hand in hand with cardiac? See the chat.
Can't breathe, yeah.
Yeah, they can't breathe. Exactly. Oxygenation.
Like-
Yep.
I feel like umbrella reasoning would be
Umbrella teaching. Exactly.
deficient knowledge is usually the reason why, and they don't adhere to the treatment because it's a chronic condition.
Yep.
And
Are
chronic
you guys
condition-
able to see my screens, or is it just the slideshow you can see? Like, can you see that I have chat up?
No, I see your slides. I have chat.
Okay. All right, cool. So then I can keep the chat open and it'll make it easier for me.
Yeah, we'll get into heart failure, but it's any chronic condition will usually be they have trouble adhering to it because it's forever.
Exactly. Yeah. But what we were saying with the rehospitalization, and something that you need to remember, because I guarantee it'll come up as part of questions, is that cardiac and respiratory go hand in hand. Because the entire time, why do you need blood flow in the first place? It's because it moves oxygen. That's how your body functions. That's how your cells function. So it brings oxygen, it removes carbon dioxide. That's the only purpose to the blood flow. So if you can't breathe, you have issues with your blood. And if you have issues pumping blood, then you're having issues with your oxygen. They go hand in hand. So remember that, because I guarantee there will be some question about cardiac, but the answer will include respiratory. Don't let it throw you off because it's a different symptom. They go together. Okay.
Try the next slide. There's something that might
Yep.
not be there. What the hell is this? Am I crazy?
What?
Yeah, I'm just disorganized. What is this? Evaluate interventions, report changes. Do I have this? Oxygen versus medication therapy, oxygen medication therapy, frequent vital signs. Oh, this is okay. I did go over this. Okay.
Okay.
Yeah.
So nursing management of ACS and MI, oxygen and medication therapy, frequent versus assessment, physical rest in bed with head of bed elevated. We elevate the head of the bed because it helps with oxygenation. If you're laying down, you're crushing your lungs. You sit them up. Relief of pain helps decrease workload of the heart. Obviously, if you're in pain, you have a higher blood pressure, you have a higher heart rate. It's just how your body reacts to pain. So decrease the pain, decrease the heart rate, decrease the blood pressure. Monitor ins and outs and tissue perfusion. Why are we doing this? Can somebody tell me why you need to monitor ins and outs for somebody who has a cardiac issue?
Because you need the fluid volume to make the circulation happen.
Exactly. Circulation helps maintain your fluid balance. So if you don't have circulation, you're going to have issues with extra water in places it doesn't belong.
Kidney function also is reduced.
Exactly.
Enough oxygen is getting to the area.
Well, that's the thing, is your kidney function is also what reduces the amount of fluid being kept in your body. So if your kidney function is not working because your blood flow isn't working, then you're going to have too much fluid in your body. So you got to monitor that. Okay, frequent position changes to prevent respiratory complications. What happens if you sit too long in one spot? And I'm not talking about cardiac, I'm talking about respiratory here. What happens to your lungs if you are sitting still for long periods of time? It doesn't have to be fancy words. What happens? None of you have sat long periods of time in a hospital bed, I see. If you're still and not moving, junk accumulates in your lungs. You need to do minimal physical activity, minimal movement to help respiration in general. That's why when you have somebody who comes out of surgery, you have them on those breathing, I can't remember the word for it. What are they called?
When someone comes out of surgery, you have them in a, what, oxygen, like nasal
No,
cannula?
it's the little machine that you do. It's
Oh,
a
intensive
breathing.
spirometry.
Yeah, intensive spirometry. That's why you do that, because you're making them use their lungs to help remove things. If you're not moving around, junk accumulates in your lungs. It sits there. So you need to be able.
I thought you were talking about like venous stasis, pulmonary embolism,
No,
which we will do that.
we will
but I was gonna-
cover.
You're like,
I'm
don't
just
use big
talking very
words, and I'm like,
general.
okay.
I'm
Well,
talking very general. I'm just personal experience, I guess. I'm throwing anything information wise at you, not just from the textbook. I'm throwing things that will help you kind of put everything together, you know? So frequent positioning changes helps you move your lungs better. If you're sitting in one place very still for long periods of time, if you're not moving, if you're not using your lungs properly, then stuff accumulates. It makes it harder to breathe. That's why people cough a lot. That's why they'll bring up sputum after procedures, because junk is in their lungs that they need to get out. So that's very important when you're talking about positioning. And then you report changes to the patient's conditions and evaluate interventions. So how well are they working? Do you need to change what you're doing, or is it working out well for the patient? Okay. Invasive coronary artery procedures.
Okay, I have more.
Go for it.
I have more for that. This is the end of angina. So the book mentions
This slide or the next one?
it's a table in the book
Okay.
within angina, and for some reason it's not mentioned in the slides at all, which it's a thing. Like I even asked her about it, and she's like, "That's weird that it's not mentioned." Thrombolytic therapy. Thrombolytic therapy is a type of therapy for you don't need to know the exact drugs, like they all end in place. You don't need to know the exact drugs. Just know that a thrombolytic therapy is the use of fibrinolytics, and lytic means lysing, destroying. It breaks up the buildup in the atherosclerotic lesions, and it increases. It's part of reperfusion therapy. They would rather. It's not as like good as using the interventions that are listed here, but the book mentions it as something that is a thing. And the book also mentions specifically that for thrombolytic therapy, it is given within 30 minutes of presentation to the hospital with, signs and symptoms of an MI, EKG, whatever. And that is known as door to needle time. Whether it comes up in an exam or not, it's 2 lines that you have to write on a paper. Indications: chest pain lasting more than 20 minutes, unrelieved with nitroglycerin. ST segment elevation in at least 2 leads that face the same area of the heart, which is, I mentioned the 2, that's a STEMI, a major heart attack, less than 6 hours from the onset of pain. And that's when you would give someone this. But they're more likely to use a PCI.
Door to needle.
Time.
So needle,
Because,
like the shot.
Yes.
You said 30 minutes?
Yes, given within 30 minutes of presentation to the hospital, if they are under these indications. If they are confirmed to have a heart attack, extreme angina that's not relieved within 20 minutes, and nitroglycerin, extreme unstable angina.
I just find that as a very short amount of time,
Yeah.
because you don't
this
always
is done
get people
quickly.
back there fast enough.
Yeah, they call it cardiac code, but that's not like, yeah, that's not this. But yeah, that's why it's fast.
No, sorry, I'm just thinking about like the ER in general. Like, I know that people obviously who they think are having an MI get pulled back faster because they triage higher, but that's still a short amount of time. If you guys have ever been to an ER, that's slow.
ER is a disaster.
It is. Like, you
So
don't
what
see a doctor and a nurse within 30 minutes. Like, fuck no.
Yeah, most of them also don't know what they're doing, and I know that for a fact, and because my mom worked.
Oh, I know.
They have to run the place. Dissolve.
I've seen it.
What these do is they dissolve the. Okay, I'll fix what I said before. What they do is they dissolve the thrombus in the coronary artery, which is called thrombolysis, which allows the blood to flow again, which is known as reperfusion, as we mentioned. So it's a quick. You know what you think heparin does? Dissolves a current clot, and also a little bit of prophylaxis. This is a big boy version of that. It literally is made to dissolve a coronary artery clot. That's what
It's made to open up the blood flow again as quickly as
it's for an
possible.
immediate thing, and that's as if they can't do a PCI, which is percutaneous transluminal coronary angioplasty, which is mentioned. That's what a PCI is.
Mhm.
And what else do I have here? So there's a door to needle time, which is that, and there's something called a door to balloon time, which
That's
is
how long it takes to get in the door until you have a balloon in that artery to open it up.
correct, and that's done in less than 60 minutes of arrival if it's
That's
needed.
never gonna happen. Jesus
Yeah.
Christ.
That's the book version of it. So evaluate for indications of reperfusion therapy. We've mentioned reperfusion therapy. This is they need an intervention for the MI. They need something to open it up, which is a stent. PCI is a balloon that goes in with the, so, okay. You can have so when you have an MI, the first thing they're gonna do, if they have to deal with it, is they go in with a cardiac cath. The cardiac cath will guaranteed identify it, but it's also used in that little camera or whatever it is. They put the balloon around it, and the balloon around the cardiac cath will blow up. And if it needs if it needs to stay open further, they put a stent in at the same time. That's what that is, and that's why a cardiac cath is so important. That's called a PCI. PCI is done alongside a cardiac cath if it's needed.
That's how it becomes an intervention, not just a imaging.
That is reperfusion therapy, one version of it, and the other version is thrombolytic therapy, which I just mentioned.
Yep.
Which is do it any whole time.
Yep. Awesome, thank you.
Yep.
Okay. So you have the PTCA, the percutaneous transluminal
Percutaneous coronary intervention, PCI.
Yep.
The
coronary
transluminal-
artery stents, the coronary artery bypass, and a cardiac surgery.
as well.
There's your PCT. This is what you're talking about, right, Adam?
That's a piece. That's the balloon.
Yep.
Yep.
So just like I was saying, they put this balloon into the artery, they inflate it to open up the artery. And then if they need to, they stent it. So they'll put a little piece of plastic or a little piece of metal. It holds it open, but it does not block flow of blood.
Yeah, the slides don't do anything for the end of this chapter. It's kind of like a disaster, but
Great.
basically the PCI is a percutaneous coronary interventions. PCIs, right? These are multiple interventions, multiple percutaneous coronary interventions. There's two. There's the PTCA, which is the transluminal coronary angioplasty, which I mentioned, which is the balloon.
Mhm.
The balloon is the PTCA, and the stent is just a coronary artery stent. So you can just say the PCI is the balloon, and if they need to put in a stent, they put in the stent along with the balloon. Now it's
Yeah,
a balloon.
you'll never see a stent without a balloon. They use the balloon to open it up. They use the stent to keep it open, but they don't always have to put a stent.
Yes. So the balloon is a balloon-tipped catheter, opens the coronary vessels and resolves ischemia. Resolving ischemia is reperfusion, blood going through. Increased blood flow through the vessel, equals coronary reperfusion. Yeah, I just wrote that. Similar process and interventions to cardiac cath. This is important. The nursing process for cardiac cath, the general anesthesia, which is informed consent, all those things is for this as well, because this is a cardiac cath as well. This is part of cardiac cath.
Yep.
So you're assessing for hematomas, pressure dressing bleeding, all that, you do the same thing.
Yep. If you need to do a
Contrast,
refresh on that, that's in the first study group
Going
online.
into the femoral artery, contrast, all those nursing interventions that are associated with cardiac cath is associated with this. And then we have the stent, which is utilized if the PTCA, the balloon, closes and needs structural support, or is predicted to close and not be enough and needs structural support. Mostly they put in a stent. They put in a stent a lot of the time.
Yep.
It holds the
Keeps it
vessel
open.
open long term. It can, there is a risk for thrombus formation, blood clot within the stent. But patients take clopidogrel for 1 year after a stent and aspirin indefinitely after a stent.
Prevents another MI and also helps prevent clot forming around a stent.
That's your antiplatelet prophylactic aspirin use. That's what that is.
Yep.
So when they say they take aspirin post-MI, yeah,
Exactly.
and that's all that.
Okay. Coronary artery bypass grafts. It's when you, in layman's terms, it's when you go and bypass the coronary arteries. It's how you change the flow of the arteries so that you bypass the blockage. Like we were saying, yeah, like I was saying earlier about my gastric bypass. It removes most of the stomach, bypasses the stomach to the small intestine. So when you're bypassing, you're skipping past it. So you're changing the flow of blood to different arteries to bypass that artery that is
So-
no longer functioning.
There's a good bit for cabbage that isn't mentioned in the
Go for
slide,
it.
so I'm gonna go over this, like, straight up. I'm just gonna go, because this is a big thing.
Go for
It's
it.
mentioned in a lot of drugs, mostly drugs that promote bleeding, like ibuprofen specifically says, do not use it with a coronary artery bypass graft. So this is the end result. This is the biggest intervention for a cardiac problem, for MI. This is the thing you don't want to have. This is the end result. This is
Yep.
when they
This is
take
the
something-
last choice.
This is when they take a greater saphenous vein or a lesser saphenous vein, if they can't take the greater, from the leg, and graft it onto the heart, so it redirects the flow past the artery that is clogged and dead. The artery is irrecoverable, so they take a vein and they graft it on so that you can bypass that artery, so that you can live. So I wrote, obviously, treatment for angina not controlled by meds or PCI. It's treatment for NMI that's not controlled by anything. You also don't have to have an MI for this to happen. This could be precautionary. They could go in. You could have extreme angina. They go in. Angina is due to coronary atherosclerosis, which is a buildup of plaque, obviously, in the artery. They could go in. You say, I have extreme angina. It's very frequent. They go in. They see that with the with the cardiac cath, and they see, wow. So this is a heavy blockage. You're at extremely high risk for a heart attack.
And probably death because of it.
They would do a cabbage. You know what I mean?
Yep. It's preventative measures when it's the last resource.
Yes, it's used for other things. I'll just list them,
Go for it.
as well as left main coronary stenosis, or multivessel coronary artery disease in multiple areas, which is not good. But yeah, this is, like I said, this is the major end intervention. So that's going to be the worst of the worst.
It's your last resort.
Yeah, treatment for complications of unsuccessful PCI. So maybe someone had a PCI stent, balloon, everything, and it didn't work out, and you have complications from that. They would do this because that artery that stuff was in is compromised. Prevention and treatment for MI, dysrhythmias, heart failure, like I mentioned. So it's a surgical procedure in which a blood vessel is grafted to an occluded artery, coronary artery. It allows blood to flow past the occlusion. The greater saphenous vein is used, followed by the lesser if you can't use the greater. That's in the leg. Lower extremity edema is a common adverse effect to the removal of the vein. So if someone is you're presented with a question where the patient just had a post-op cabbage, and they have edema, and it would say, which of the following is the most important thing to deal with? Which of the following is the most important complication to deal with? Know that edema is a common adverse effect to it. It's very common. It's general anesthesia, obviously, much like cardiac cath. This is the next level of that. So it's general anesthesia. You need informed consent. Same thing. Nothing by mouth. Very important as well. Okay. And then there's something called, you can move on to the next slide, I think.
Okay.
That's
Yeah, so this is the vein that they take to do the bypass.
Okay, next one. This is called a cardiopulmonary bypass system. This is something that enables you to have cardiac surgery, like open heart surgery, anything. This makes it so that your heart doesn't have to beat in order for you to get circulation. This enables, because your heart's going to be stopped during these surgeries. So this is what is bypassing, the heart, so that the
This is
blood flow
this
to
is
your
what
body.
The bypass machine turns into your heart. That's what's circulating your blood while they stop
Right.
your heart from beating during surgery.
Mechanically circulates and oxygenates blood while bypassing heart and lungs. This enables heart surgery. Hypothermia is maintained during all of these surgical procedures. During any surgical procedure, you maintain hypothermia.
Yeah. They
Don't ask me why, I don't remember. I just know it's a thing and it's listed in the book.
the lower body temperature means that your heart needs to beat slower. Like if you think about it, when you have hypothermia in nature, your blood pressure drops, your heart rate slows, and your breathing slows. So because of this, it's less work on the bypass system or what would be your heart in real life.
The cold temperature reduce the metabolic rate.
That's
Exactly.
right. That's right. Okay. No, I haven't done it in a while. Someone brings up like 2 keywords. You remember what it is.
Yep.
All right. So now you can move on to the next slide. That's the
Okay.
gist of these. And here's the big thing, the interventions.
You want me to go for it?
Yeah, I can expand on it after.
Okay. So we got patient required invasive cardiac interventions. You have assessment of the patient, reduce fear and anxiety, monitor and manage potential complications, provide patient education, maintain cardiac output, promote adequate gas exchange, maintain fluid and electrolyte balance, and minimize sensory perception imbalances.
All right. So I went really hard on the book lists a lot of nursing interventions for coronary artery bypass graft.
Yeah.
I did too much, but that's for me. I can like absorb that, but most people can't, obviously.
Yeah.
So it's not reasonable to go through it all. So I'll go through it reasonably.
Yeah.
So for assessing the patient, we did history and physical, meds, surgical history, risk factors. Okay, that's obvious. Diagnostics pre-op that are taken are, this we don't need to know. Obtaining baseline of patient, obviously pre-op. PACU, okay, this matters, even though we aren't doing that because she brings it up in class 100 times.
Okay.
Post, let me see, I don't want to say the wrong thing. In the PACU, post anesthesia care unit, because you're going to be in PACU after the surgery because it's anesthetic.
It's
general.
recovery.
You want to assess all systems every 4 hours,
Yeah.
but there's a specific range that she wants you to assess pulses. And she's brought this up in class and it's going to be on the exam. And I think it's worth it for me to go back and get the proper range, right? Because it's in the cardiac chapter we did.
If you think that it's going to be important, go for it.
She mentioned it. She may even mentioned it to me in meeting, like
You meet with them so much, dude.
every single time I can. Yeah, whatever. It's 30 minutes worth.
I guess. I don't know. I don't even know what the fuck I would say to them.
I just ask them questions and I try to get them to answer questions they might not want to answer. I know it's here. Okay, so we're going to talk about a little bit about post-op cabbage, right? And cardiac catheterization as well, because that's what this is based on, because it's the same.
Yep.
This is the
Remember
same
it. It's
post-op. It's not
important.
the same procedure, but it's the same post-op.
Yep.
Bed rest for 2 to 6 hours prior to ambulation. Same thing, and she's mentioned this 100 times. Okay, observe the site for bleeding or hematoma and assess peripheral pulses in affected extremity. Okay, so this is assessing peripheral pulses, and I have the range. You want to assess the pulses post-op every 15 minutes for 1 hour. Then every 30 minutes for 1 hour. So that's twice. So that's what, 4 times for the first hour, twice for the second hour. And then after that, hourly for 4 hours, which I said you assess all systems every 4 hours. This is after that. Or discharge. Or until they're discharged, you know?
Yep. We learned this last semester. I don't know how many of you remember it. I remember going through it though.
Yeah, those
Uh,
are the two things she brings up, the bed rest and that a million times.
Yep.
And
It's
what do I-
important. You have to monitor their vital signs multiple times at certain intervals. We learned it last semester during clinical assessments.
you'll get into it more, but this is specifically mentioned here, so I'm bringing it up.
Yeah.
And review symptoms. Intermittent claudication is brought up, which is leg pain that occurs while walking. That's what it is. Chest pain, dyspnea, peripheral edema, and palpitations. These are major post-surgery adverse effects.
Yep.
Okay. Reduce fear and anxiety is here. I have nothing for it. It's obvious. You
Yep.
know, make sure, reorient them, make sure they know what's going on, answer
Calmly.
the questions they have.
Education is the best way to decrease anxiety in a patient. Point blank. Obviously, if they're having
guys.
hi. Obviously, if they're having an acute anxiety attack, education is not the time. But that's when you use the breathing exercises to calm them down, try and slow their breathing. It's the easiest way to stop a acute anxiety attack. And then when they're calm and they're in a place where it is acceptable to be able to absorb information, that's when you do patient teaching. That's when you teach them about whatever is going on, and that can help decrease their anxiety.
Monitor and manage complications. This is a book. Any post-op complication, extreme bleeding, hemorrhage, angina, like extreme chest pain.
Yep.
Because that's a blockage. That's not the whole, that's the purpose of this, is to avoid a blockage.
Yep.
Dyspnea, not being able to breathe well during this, is an actual, in this case, post-op is a significant thing.
Yep.
Peripheral edema, not good. Well, okay, no, that's not true. Peripheral edema, I caught myself. Peripheral edema is common in this. Lower extremity edema is common to vein removal. So that's common here, but you still want to assess it to make sure it's not progressing upwards.
Exactly. It
And
needs to
heart
be
palpitation,
maintained.
during this as well.
It needs to be maintained, and it needs to be decreased. You don't want to see an increase in it. You want to see it getting better.
Yes.
But it is a common thing that you will see.
Okay, and then after that, I have patient teaching.
You have what?
Doesn't say a damn thing about. So patient teaching pre-op, medications that must be stopped prior to the surgery, and this was brought up to me specifically as well. Because the main thing about coronary artery bypass graft and its surgical aspect is you want to make sure they don't come back with complications, and you want to make sure they can have the surgery. Because if they can't have the surgery, they're going to freak out. So medications that must be stopped are their anticoagulants, obviously, their antihypertensives, and their diabetic medications. Don't ask me why diabetic medications, I don't remember, but it specifically mentions those.
It can
Those must
affect
be
your
stopped.
blood.
Yeah, those must be stopped prior to the surgery.
Most surgeries.
Can I just ask you guys where you are? Sorry.
Oh yeah, sorry. We're in chapter 27. We're at about slide 41.
Towards the end.
42, yeah, sorry.
Yeah, coronary artery bypass graft.
Yeah, these are the cardiac interventions that we're going over from the cardiac bypass.
Okay. Thank you.
All right. Yeah. But yeah, when it comes to those medications, most procedures and surgeries, you need to stop those. You need to stop the anticoagulants. You need to stop, because at the end of the day, you want to prevent risks of bleeding. So when you're doing procedures, when you're doing surgeries, the risk of bleeding needs to be as low as possible. So you can't take those aspirins, NSAIDs, anything that's going to affect your coagulation at all. So you stop those at least a week, 10 days beforehand, unless otherwise told by your doctor. So if they're having cardiac issues, it's a high possibility that they're taking a maintenance level of aspirin. That's an anticoagulant. So you need to talk to your doctor and find out, should I stop taking that?
Antiplatelet.
Oh yeah, sorry,
And
antiplatelet,
I
sorry.
catch you on it. Yeah, that's a
Um,
neat. That's a neat thing.
Yeah, it's antiplatelet. So it affects your coagulation. So you need to make sure, well, am I supposed to stop this? Because I'm at a risk for an MI if I don't stop it. So talk to your doctor, find out if you're supposed to stop taking that. But when it comes to over the counter, you don't take it anymore.
So some other patient teaching, the chapter mentions is showering pre-op. This is all pre-op right now.
Yep,
Showering with an aseptic solution.
which
That
the
they'll give.
hospital gives you.
Yep. Hair removal with an electric clipper, not razors. This all comes up again in a later chapter, but the book mentions it in this chapter as well. Equipment. What is this? Let me see. Oh, you want to, make the patient aware of the equipment that's going to be used and the sensations that will be felt. This is for any procedure. It's mentioned in cardiac assessment a lot as well. You also want to tell them how long the procedure is going to be so they know what to expect. It reduces stress, fear, all those things.
This is mostly patient teaching that you will just be there to observe and sign off on. So this is teaching that when you go for a procedure, you're brought into the procedure area. They're setting everything up in your surgical room or your procedure room, and you're going to have your doctor who's performing the procedure come and talk to you. They have paperwork. It has all the information about what's going to be happening during the procedure, the risks involved, and the patient will sign off on it, and then you will sign off that you observed this interaction. So most of this teaching is not necessarily from the nurse, it's from the doctor, but you have to be aware of all of it happening.
The nurse can do these. The nurse can
Can,
tell them,
but they can't,
equipment, not necessarily
they
get
cannot get
sensations and,
consent.
no, consent is different than this.
Well, this is informed consent to an extent.
Informed consent has a lot. Well, you'll do the chapter associated with it, believe me.
Yeah,
But there's a whole page of it.
Yeah.
And you got to know the whole thing. This is patient teaching to reduce like anxiety and different things like that. So you can do these things. Intubation will prevent speaking. This is something the patient needs to know. The patient needs to know. This is something the surgeon will say. You know what intubation is. You can explain what intubation is. You can explain the patient that intubation will take place. Intubation.
yeah, I'm not saying that you don't. I'm just saying that you'll also observe this during informed
You
consent.
observe that this was all asked.
Yes.
Intubation is general anesthesia. And general anesthesia is intubation. General anesthesia of the procedures that we are aware of are cardiac cath and coronary artery bypass graft. Those are general anesthesia. The patient will be intubated. They have to know that they won't be breathing on their own. And they will remain intubated for a few hours after surgery, which is something that you, as the nurse, will also encounter.
They'll usually still be out, though.
Yes.
They're usually not on
It
intubation when they
doesn't
wake up.
That's what I'm just saying what it mentions.
No, I'm just adding.
Stop deep breathing, coughing, and incentive spirometer use, and foot exercises. You'll teach them how to do you'll tell them to do these things. And you want to answer any questions they may have. That's in general.
Yep.
Next, we have maintain cardiac output. It's here too. Yes. So routine measurements of, blood pressure, CVP, heart rate, arterial pressure, pulmonary arterial pressure is going to be done. Your GFR is related to your cardiac output. We mentioned that.
The GFR level is written on that level sheet I showed you guys that's on Blackboard.
Yeah, it's straight from the chapter. It's urine output. Well, this is different. Urine output of less than 0.5 milliliters per kilogram per hour is indicative of decreased cardiac output or inadequate fluid volume. So these are the numbers the book. This is specifically the book says this.
Yep.
So if you want to write that down, that's a thing.
Can you just repeat the number?
Urine output of less than 0.5 milliliters per kilogram per hour is indicative of decreased cardiac output.
When it says per kilogram, that means the weight of the patient.
The weight, yeah, the pounds divided by 2.2.
Yep.
Or inadequate fluid volume, which hand in hand.
Yeah. Very unlikely though, because they'll probably be on an IV drip of some kind.
Yeah, exactly. Oh, yeah, could this fluid overload thing we'll get into.
Yeah.
I have something written here. I'm just going to read it out loud. The book says all of this. Whether you want to write it down or not is up to you. They're all interventions. Buccal mucosa, which is the lining of the cheeks and back of the lips, nail beds, lips themselves, earlobes are monitored for cyanosis, which is blue, blue color, / duskiness. And if that's present in those areas, it's a sign of decreased cardiac output as well.
Yep, because you're having low oxygenation to those areas.
It specifically mentions monitoring for those areas. Distension of neck veins, jugular vein distension, JVD, with the, okay, I'll just say this in general because it comes up in the next chapter as well, so we just get it out of the way. Jugular vein distension is the distension of the jugular veins, right here. The jugular veins are visible when you're laying down flat and the head is elevated 30 degrees. That's when you can see the jugular veins. So if you have JVD, when the head is elevated 30 degrees, you'll see them popping out. That's that. Yeah. And it's a sign of right-sided heart failure, which we'll get into, but it specifically mentions that here as well. Monitor for AFib, tachycardia, bradycardia, ectopic beats. These are all severe dysrhythmias associated with cardiac surgery.
They'll be hooked up to an ECG. That's how you monitor all these.
Promote adequate gas exchange I have here.
Mhm.
See anything important here? Assess and maintain potency of endotracheal tube because they will be trached for a period of time. Suction when crackles or coughing, which we do tomorrow.
Yep.
ABGs are obtained, arterial blood gases are obtained and compared to their baseline. When
Yep, you take a baseline ABG and then you monitor it.
When hemodynamics stabilize, hemodynamics are central venous pressure, blood pressure, all that stuff. When those are all stable, you want to instruct the patient to change their body position every 1 to 2 hours on their own. We'll also be assisting with endotracheal removal, which I have an intervention for, but it's whatever. It is a thing as a nurse, you will assist with endotracheal removal.
Yeah, that's something we'll
You'll
probably
also
cover more in clinical.
You'll do it in skills lab.
Yeah.
Maintaining fluid and electrolyte balance is on here.
Yep.
That's obvious. Assessing and taking output. Including NG tube drainage, whatever, hemodynamics, CVP, blood pressure, cardiac output. Serum electrolytes are being monitored. Signs
Does
of
everybody know what an NG tube is?
nasogastric. Feeding
I
tube.
know you know, Adam.
Oh no, well, yeah, people.
Anybody else? What's an NG tube? Well, Adam already said it's nasogastral. So how does it work? What happens? Why do you use it? Anybody? Anything? What do you know about NG tubes?
I honestly don't remember.
Okay, so NG tubes, it's a tube that goes through your nose down to the stomach, and it's how some patients will be getting their nutrition because they cannot physically eat. So that's what an NG tube is. So you have to, that also gets monitored.
Yeah, for intake and output, you assess NG tube. You assess whatever they take from that, drainage from
Urine.
thing, and yes.
Yeah.
Signs of potassium, magnesium, sodium, and calcium imbalance are massive. That's heart. Just know they have to do with the heart.
Well, sodium and potassium have to do with how your heart beats.
That's
So
contraction.
those levels are very important.
Sodium is also fluid retention. But
Yeah.
monitor for fluid overload. That's on here. Which is edema, jugular venous distension, which is mentioned now. Okay, minimizing confusion, which isn't mentioned here. That's what they mean by minimize sensory perception imbalances, minimize confusion. It's just reorient the patient. That's it.
When you're
However,
coming out of anesthesia, you can be very confused sometimes. So they might not immediately remember where they are, what's going on, why they're in pain, what they're feeling. So it's just making sure that you can tell them you just came out of your procedure, everything went well or whatever. The doctor will come and see you and talk to you about what happened. You're okay.
yeah, frequent reorientation is the intervention for that. There's a specific thing to coronary artery bypass graft that if you haven't written down any intervention, you should write this one because it's very specific and it's brought up multiple times.
Yep.
So for minimizing confusion, an instance of delirium, specifically delirium, post cardiac surgery, coronary artery bypass graft, the instance of that is increased with age. So it's a gerontologic thing. So the older the patient is, the higher the instance of delirium after the coronary artery bypass graft. And it will not appear, it typically appears after 2 to 5 days of a stay in the ICU. So they might get it after they're discharged. They might have delirium. They might, you know what delirium is. So that's a big thing, delirium, the word.
Do they know why it happens?
I don't remember. I
Okay.
didn't, that was too much. I wrote too
Yeah.
much, that's too much.
I was just wondering.
Yeah, the word's enough.
Okay.
Relieving pain, we know what relieving pain is.
Yep.
Maintain adequate tissue perfusion. Peripheral pulses palpated to assess arterial obstruction. We know this, and we know the interval now.
Yep.
Embolism signs and symptoms. We'll get into that later in the next chapter. We'll get into that.
Mhm.
Embolism is pulmonary embolus. You know, an embolism is a blood clot that breaks off and moves. And the worst one is when it breaks off and moves into the respiratory system.
Yep.
Moves into the, it moves into the lungs.
Lungs.
So you have a clot in the lungs. Prevent venous stasis. This isn't mentioned in the next chapter, so I'm going to mention it now. Venous stasis is a DVT, deep vein thrombosis. You know what that is? It's a blood clot in the leg from sitting too long, stuff like that. If you go into the hospital in clinical and you see someone with an SPC, a sequential pneumatic compression device, you know, the thing that like pulses on the.
They're like stockings.
Those are stockings.
Well, there's
are different.
stockings, which you can put on patients to just help blood flow in general. And then you also have the
pump.
actual wraps. They'll go around the calves of the patients, especially after surgeries, and it pumps in air. So it'll squeeze and then release, and that helps blood flow move to prevent the blood clots.
You'll see this almost every post-op. You'll see this.
Yep.
The patient, if the patient can't move, this is what they're going to use.
Most patients will refuse them or try to take them off. Do not let them do that. It's going to cause a blood clot.
So also this is mentioned in class as well. So she mentioned DVT. She mentioned to prevent venous stasis. So I'm going to mention all the things that are associated with it that she also mentioned in class. Discourage the crossing of legs, obviously. Avoid elevating the knees in the bed. Omit pillows in the popliteal space, which is behind the knee. And passive exercises and active exercises increase circulation. Okay. We already mentioned urine output less than 0.5. Maintain normal body temperature. Remember, the patient is normally hypothermic following the surgery. So
Yeah,
in that
after
stage,
surgery, they
hypertension is
increase
not common.
After a patient comes off of the cardiac bypass machine, after procedure, they restart the heart, they stop the bypass machine. The blood is now being pumped again by the heart. They will increase the body temperature again after surgery, but you need to make sure that you can maintain body temperature, because also we've talked multiple times about how temperature changes how the dilation of the veins. So if you are too cold, you're dilated, so you're not getting the adequate blood flow.
Yeah.
So you need to
Post-
maintain body temperature.
Yeah, so post-coronary artery bypass graft, shivering and hypertension are common. Like
Yep.
they will until they're stabilized. Cess for infection, obviously. Fever decreasing meds may be used, not ibuprofen. And I wrote this down because she, in a meeting I did with her, she brought up a question, which it's not an exam question, but it would be a good one. Where she's like, post-surgery, you know, post-coronary artery bypass graft specifically, she says, you know, the patient has a high temperature of like 101. What medications would you use? She listed like Lasix, acetaminophen, ibuprofen, and stuff. And if you overthink it, you might come to the conclusion that it's acetaminophen because it has a similar action to aspirin. But no, it's ibuprofen. Ibuprofen is the one you wouldn't want to use because it increases bleeding directly. And the chapter that it's in specifically states that it is not to be used post-coronary artery bypass graft. So I wrote not
You want
ibuprofen.
to avoid anything that is going to change the coagulation.
Yeah. So she said acetaminophen is good. Acetaminophen.
Anytime you're dealing with a patient who has issues with coagulation, acetaminophen is the only option.
Well, that's
If you're dealing with somebody who you
You
need
want
to
your fever
prevent
to-
bleeding, After a coronary bypass, you want to prevent bleeding. That's the main thing you're looking for. So if you're giving them a drug that is going to possibly increase the chance of bleeding, you don't want to do that. So it's very obvious that you avoid any drugs like ibuprofen that will cause bleeding. So acetaminophen doesn't have that factor. It just reduces fever.
Yes, acetaminophen has an action that has the very similar action to aspirin, so it would counteract the effects of aspirin, which is also a good thing. So that's, yeah, there's a lot of overthinking, but this is
Yeah.
not overthinking. This is it. Okay, and then we
I
have
like to
something,
oversimplify.
yeah, then we have something called post-pericardiotomy syndrome. This is a syndrome that will experience post-coronary artery bypass graft. A lot of the time, it's fever, pericardial pain, pleural pain, which is lungs, dyspnea, pericardial effusion, also lungs, friction rub, arthralgia, these are lungs.
Yeah, friction rub is lungs. That's if you don't have enough of the interstitial fluid to prevent the rubbing.
I wrote that you must differentiate between other post-op complications, but ignore. So yeah, just know that post-pericardiotomy syndrome is a thing, and it's a lot. It's a lot of like lung conditions. May occur days to weeks post-surgery. Okay, and then I have patient teaching. The patient will be discharged within 3 to 5 days usually. Help them set realistic goals. Okay, the patient is to follow specific instructions following discharge. And the whole point of this is to prevent rehospitalization. You prevent rehospitalization by having them follow these specific instructions. So it's a big thing.
Yeah.
These would include incision care, infection signs and symptoms. They have to know what to look for. They have to follow the diet they've been put on, the exercise regimen they've been suggested, deep breathing and incentive spirometry, tobacco use cessation medications. They should monitor their weight and temperature, and they should keep their follow-up visits. And that is
Yep.
what defines that as.
Perfect.
And they will
right.
have another thing associated with this that the book mentions. There's big things. You can gather what the big things are that I'm mentioning. I really went in depth with this because the book goes in depth with it.
Yeah.
Delirium. Remember when I said delirium?
Yep.
As a major thing. The book mentions learning and memory difficulty will be common in every patient, just general, not delirium necessarily. That's with age, but memory and learning difficulty. So trouble writing and stuff and remembering things, that subsides in 6 to 8 weeks. So the patient just needs to know that memory and learning difficulty they may experience will subside in 6 to 8 weeks. And
That
they
can
should
be
go-
common with anesthesia in general. That can affect your memory.
Yes, this is for 6 to 8 weeks. Go at a slower pace than normal until it subsides.
Perfect. All right, we're gonna end this chapter with a question. Adam went over the answer pretty much, so you all better know the answer. Who wants to do it?
Is it D?
Yep. The sequentials, you want to prevent blood clots, no crossing the legs. Everything else is wrong. You don't use pillows, you don't encourage leg crossing, and exercise helps blood flow. So the answer is the sequentials, exactly,
I
perfect.
just want to let you know our class did not go over like a single pre-post-op conversation like one time.
Okay.
Yep.
Any of these things, like not a single time we mentioned this.
That's
Yes,
why we're
she's not-
doing this.
She's not going to.
She's not. Absolutely ridiculous.
yeah. That's why we're doing this. Okay, so let me stop sharing and we will go and do chapter 29
Oh yeah,
now.
this is the chapter. Fixing notes.
You guys know what's going to be on the quiz? Did Erickson mention anything?
No, not yet.
Cardiac.
It's mostly cardiac,
assessment and
and
the
you
four
want to
cardiac.
focus on the cardiac drugs, but it's not guaranteed to be the only drugs. But
Right.
drugs are a very big thing that we need to know. So definitely study your 115 material. So any drug that is listed in our syllabus from the very beginning until what we've covered, make sure you know those drugs.
For our 120 syllabus.
Yeah, for the 120 syllabus.
Yeah. Okay.
It has a list of drugs that go with each chapter. So just study all of the ones that have said we've covered so far.
Well,
You're
our
not-
class didn't cover any of them. We don't even talk about prototypes.
We
so-
don't talk a lot about them in
She
super
goes over
depth.
drugs. She goes
We
drugs over-
did, yeah, when we did the cardiac chapter, she did go into a little more. She had some of us do like verbal prototype almost of it. We went over like 3 different types, just like to get the generalization of the different like what a channel blocker was, what an ARG was, or whatever. So like we went into some detail,
Yeah.
but we don't go over all of them in detail.
Okay.
So it's pretty much just pulling out the prototypes and just studying them.
Yeah. Okay. Also, she said it's gonna be some multiple choice and some short answer.
Great.
Yeah,
The short answer is gonna be
25 questions.
nursing interventions. That's what it's gonna
Yeah. Nursing interventions is for extended response, you said?
be. Yeah, always. That's
Okay.
what she's done before.
Okay, that's good. It's a little easier to do.
Yeah.
Nursing interventions are very important. We've been covering
You
them.
really
nonstop.
got to know like the issue is and what to do for it.
Yeah. All right.
Okay,
So moving into chapter 29, management of patients with complications. Whoops. From heart diseases. So we have a clinical syndrome resulting from structural or functional cardiac disorders that impair the ability of the ventricles to fill or eject blood. In the past, heart failure was often referred to as congestive heart failure because many patients experience pulmonary or peripheral congestion with edema. Heart failure is recognized as a clinical syndrome characterized by signs and symptoms of fluid overload or inadequate tissue perfusion. We've said before this chapter that when it comes to your heart pumping properly and doing the job that it needs to do, it can affect how your kidneys work, and your kidneys have a big influence on how much fluid is being kept in your body. So if your heart is not functioning properly, then your kidneys probably are also suffering, and you're going to have extra fluid, which would be that edema. Okay. The term heart failure indicates myocardial disease in which there is a problem with the contraction of the heart, systolic failure, or filling of the heart, diastolic failure. Some cases are reversible depending on the cause. Most heart failure is a chronic progressive condition managed with lifestyle changes and medications. Just let me know when you want to stop me, Adam.
Let me see. We're up to chronic heart failure. No,
We
yeah, that's
just did
fine.
heart failure.
That's fine. Heart failure is mainly chronic. Yeah.
Yeah, chronic heart failure. The incidence of heart failure increases with age. Approximately 6 million people in the United States have heart failure, and 870,000 new cases are diagnosed each year. Most common in people older than 75. Most common reason for hospitalization of people older than 65, and is the second most common reason for visits to the physician's office. Approximately 25% of patients discharged after treatment of heart failure are readmitted to the hospital within 30 days. And like we said before, when you have somebody with heart failure, usually they'll show up to the hospital because they're having issues breathing. Because when you have heart failure, you have failure with your respiratory system as well. The pathophysiology of heart failure includes all of your organs, because if your heart is failing, you're not getting proper oxygenization, which means that your all of your other organs are not getting oxygen, which means they're going to slowly deteriorate, which means a lot of issues for all of your organs. Make sense? Okay. Clinical manifestations. When you have right side heart failure, it's visceral and peripheral congestion. The JVD, the jugular venous distension, which is when you can see the jugular distended, it's going to be like swollen almost looking. You'll see that. It's dependent edema, hepatomegaly.
Hepatomegaly.
Thank you.
Hepato is liver and megaly
Yep.
is enlargement.
Okay, so enlarged liver. Ascites and weight gain. When you have left side heart failure, you have pulmonary congestion and crackles. You have the S3 or the ventricular gallop. So you'll hear that in your assessment of the heart when you're listening. You'll have dyspnea on exercise, low O2 sats, dry, non-productive cough initially. Adam, what's this last one?
Oliguria,
Yeah,
decreased urine production.
okay, thank you. All right.
I can add something here. So a good way to remember it is right-sided heart failure, edema, left-sided heart failure, pulmonary congestion.
Yep.
All things.
Well, you just have to remember the right side of your heart deals with the rest of your body. The left side of your heart deals with your lungs. That's how it is divided. Okay. Medications. The angiotensin converting enzymes or ACE inhibitors. They vasodilate, they're diuretics, they decrease afterload, they monitor, you monitor for hypotension because it drops your heart rate. You monitor for hyperkalemia and altered renal function, as well as experiencing a cough as a common side effect. When you have the angiotensin 2 receptor blockers, it's prescribed as an alternative to an ACE inhibitor, but it works similarly. The hydralazine and isobutyric dinitrate. It's an alternate to an ACE inhibitor. And then we have beta blockers. They're prescribed in addition to the ACE inhibitors, and they may be several weeks before effects are seen. And you use with caution in patients with asthma. We all know that pretty well, though, with beta blockers. Avoid with asthma. That was very important last semester.
Did you guys do milrinone?
No.
It's mentioned in this chapter. So obviously avoid ibuprofen with all this.
Yep.
So if a patient is hospitalized due to acute decompensated heart failure, which is like a major flare-up of heart failure, it's like something they would be hospitalized for. They are given IV milrinone. Caution, it's a big thing, and the book emphasizes this a few times. They're given milrinone, which is, I have a drug card for this, so we did do it at one point. Yes, they're also given nitroglycerin, aceratide, and dobutamine, which is coming up again as well. And that's only if they're hospitalized via
Yep.
IV.
Okay. Medications too, we got diuretics. They decrease fluid volume. You monitor the serum electrolytes because the more fluid they're releasing, the more electrolytes they're releasing. They need to be able to keep an electrolyte balance while also decreasing the fluid volume. Digitalis, it improves contractility. You monitor for digitalis toxicity, especially if patients are hypokalemic. IV medications indicated for hospitalized patients admitted for acute decompensation heart failure. The milrinone decreased preload and afterload, causes hypotension and increased risk for dysrhythmias. And the dobutamine is used for patients with left ventricular dysfunction to increases cardiac contractility and renal perfusion. So that's going to increase the cardiac output, and it's going to increase how much fluid your body is getting rid of. For older patients, you may present with atypical signs and symptoms such as fatigue, weakness, and somnolence. Decreased renal function can make older patients resistant to diuretics and more sensitive to changes in volume. So you have to make sure you're monitoring their fluid in and out. Administration to diuretics to older men requires nursing surveillance for bladder distension caused by urethral obstruction from an enlarged prostate gland. That's pretty straightforward. Question, which classification of medications play a pivotal role in the management of heart failure caused by systolic dysfunction? ACE inhibitors, beta blockers, diuretics, digitalis. Anybody? Other than Adam? Which medication is for right systolic?
Digitalis? Is it?
What?
Is it digitalis? Oh,
No,
it is B then, I think. I don't know.
nope.
Okay, I got it
We're
all
ju-
wrong.
We're doing ACE inhibitors. That's okay. At least you friggin' opened your mouth. ACE inhibitors. They play a pivotal role in the management of heart failure caused by systolic dysfunction. Beta blockers have been found to reduce mortality and morbidity in patients with NYHA class 2 or 3 heart failure by reducing the adverse effects of the constant stimulation of the sympathetic nervous system. Diuretics are prescribed to reduce excess extracellular fluid by increasing the rate of urine production in patients with signs and symptoms of fluid overload. And digitalis increases the force of myocardial contraction and slows conduction through the atrioventricular node. So
What is systolic dysfunction?
systolic dysfunction, it's when the
I was
go
gonna
for it.
mention that. So let me just make sure I'm right. Is ACE inhibitor the primary treatment for heart failure in general? Let me see.
yes, for white people, yes.
Okay, because
ACE inhibitors is the go-to for white. For African American, you go with calcium channel
Calcium
blockers.
Okay, yes. So the heart failure that we're speaking about is also all systolic. Systolic heart failure is a weakened heart muscle. Any heart failure that's involved with a decreased ejection fraction, meaning decreased cardiac output, is systolic heart failure. Diastolic heart failure is a stiff, non-compliant heart muscle, whatever. But for diastolic heart failure, your ejection fraction is normal.
Systolic
You have to deal with an ejection fraction that's decreased, not normal.
Yeah, so when you're dealing with systolic dysfunctions, you're having issues with cardiac output. When you're dealing with systolic, you're dealing with the flow of blood into the heart.
So this question is basically asking you, since we're basically talking about heart failure, the chronic heart failure is systolic heart failure essentially, because it's decreased cardiac output. So this question is basically asking you, what is the primary medication for heart failure? ACE inhibitor.
Exactly.
Doing it in a tricky way.
Yep. And that's the thing, is they're going to try and trick you. But that's what you have to remember. As long as it doesn't say you're dealing with an African American patient, the main drug you try is ACE inhibitors. Okay. Care of patients with heart failure assessment. For a focused assessment, you need effectiveness of therapy. So how well what you're giving them is working. Patient self-management, how well are they following the care plan that you gave them? Signs and symptoms if the increase of heart failure occurs, and then the emotional or psychosocial response. Always a health history, and then PE, mental status, lung sounds, crackles and
Pulmonary embolism.
wheezes.
Oh no,
Yeah.
physical examination. That's dumb that it says PE, because pulmonary embolism is in this chapter.
Yeah,
It's physical
but it's
examination.
well,
Yeah.
it's what you need to assess for too. So with pulmonary embolism, we're going to get into it a little bit in more detail, but it's the blood clot in the lung, pretty much. So mental status is affected, lung sounds affected, you'll hear crackles and wheezes, heart sounds change, the S3, which is that extra beat, the galloping sound, the fluid status or signs of fluid overload, daily weight ins and outs, and assesses responses to medication. You have diagnoses, which is activity intolerance related to decreased cardiac output, excess fluid volume related to heart failure syndrome, anxiety related symptoms related to complexity of the therapeutic regimen, powerlessness related to chronic illness and hospitalizations, and ineffective family therapeutic regimen management. So when it comes to, this is just pretty much what's going to happen because the patient has heart failure. So you're going to see that they can't do as much activity. You're going to see fluid volume excess. You're going to see the anxiety related to the symptoms they're experiencing and how difficult it is to manage what they're dealing with. You're going to see mental problems and mental status changes, which is the powerlessness, which could show as anxiety or depression related to being chronically ill and having to be in the hospital all the time. Being in the hospital and having a chronic illness is very, very, very heavy on a person's mental status. Being sick is very difficult for people to handle. And then ineffective family therapeutic regimen management is just how well is their lifestyle changing appropriately, and how well is the family lifestyle changing? Are they being supportive? Is it easy for them? Are they being able to do it? All of those things. Okay, potential complications and problems. These are things that go with heart failure. You got hypotension, poor perfusion, and cardiogenic shock, dysrhythmias, prothromboembolism, and pericardial effusion and cardiac tamponade. So those are things that you'll see in addition to heart failure. Nursing process, the care of the patient with heart failure, planning. So your goals is to promote activity and reduce fatigue, relieve fluid overload symptoms, decrease anxiety or increase the patient's ability to manage anxiety, encourage the patient to verbalize his or her ability to make decisions and influence outcomes, educate the patient and family about management of the therapeutic regimen. So these are the things that we're aiming for the patient to be able to do: increase activity, reduce fatigue, being able to manage their fluid levels, being able to decrease anxiety, understanding their situation, being able to communicate with their family members and their physicians and nurses about how they're feeling, how they're handling things, what's going on, all of that stuff. Okay, activity intolerance. Bed rest for acute exacerbations. So that means when you're having an acute exacerbation, when you're having an episode, rest. You want to encourage regular physical activity, which is 30 to 45 minutes daily. Exercise training, pacing of activities. So like we said, you're going to be doing alternations of activity and rest. So you can't do everything all back to back to back. You need to have rest periods in between. Wait 2 hours after eating for physical activity. As we said before, eating a heavy meal, that takes a lot of blood to your stomach, which means you have higher cardiac output need. So you don't want to add physical activity on top of that. It's just your heart would not be able to do both at the same time. Avoid activities in extreme heat, cold, or humid weather. Modify activities to conserve energy, and then positioning, elevation of the head of bed to facilitate breathing and rest, and the support of arms. Any questions? No questions? Okay, gonna move on. Fluid volume excess. You're gonna assessment for symptoms of fluid overload. You have daily weight, the ins and outs that should be recorded, diuretic therapy, the timing of meds. When do you give a patient a diuretic? You should all know this. When do you give a patient a diuretic? What time of day?
Yeah, chat. It's in the chat. It's in the chat.
Oh, it's in the chat. Sorry, I
Yeah.
can't see it. Yep, in the morning. Thank you. All right, you give them diuretics in the morning because that is when you want them to pee. They're going to be peeing nonstop. They're not going to want to do that at night. When do you give their blood pressure medications, anything, any kind of heart medications? What time of day do you do that? When do you give heart medications? We learned this last semester, guys. Come on. Heart medications, yes. Thank you, Victoria. Heart medications are giving at nighttime. That's when your heart rate and your blood pressure is higher. So that's when you give it. It also helps to prevent chances of having episodes of hypo. I just lost the word. Wow. Low blood pressure. You don't want to have a patient who's in the middle of the day walking around and all of a sudden they have low blood pressure and they drop because their blood pressure was too low. So you give that at nighttime. Okay. And then fluid intake and fluid restrictions as needed, and maintenance of sodium restrictions. If you have too much sodium, you're going to retain water, and that's the opposite of what you want to do. So you reduce your sodium intake. Next, patient education, medications. Obviously, whatever medication they are on, you need to educate them on when to take it, how to take it, if they have to take it with food, without food, every single time of day, same day. I mean, every single day at the same time, what their possible side effects are, why they're getting the meds, if they should be using them, is it okay to use if you're pregnant? All that information about the drugs you need to know to educate your patient. You're going to educate on diet, which should be low sodium and fluid restriction. You're going to monitor for signs of excess fluid, hypotension, and symptoms of disease exacerbation, including daily weight. You're going to do an exercise and activity program, which it's mostly going to be from like a nutritionist talking to, that's the people who are going to deal with like what diets they're on, what kind of exercises they should be doing, but it's also an education point for you as well. Stress management, as we said multiple times, prevention of infection, pretty obvious. We all know how to do that and what the signs and symptoms of infection is. You need to know how and when to contact a healthcare provider and include family in the education. Having a support system is the best way for patients to handle their situations a lot of the time. So if they want to include their family members into their medical issue, then educating family members can also be very helpful, because sometimes, most of the time, you're going to be dealing with elderly patients when it comes to the heart failure. So they're going to need help with shopping for groceries, preparing meals, exercising, all of that they're going to need assistance with. So educating the family properly is very helpful in that situation. What evaluation most illustrates that the patient with heart failure has met outcomes for the nursing diagnosis? Activity intolerance related to decreased CO, which is cardiac output. So the question, you want to see who has met the outcomes for activity intolerance related to decreased cardiac output. So which one of these is the answer? It's in the chat. I cannot see it. B. Okay, everybody's saying B. Let's see what we got. Yep. Maintain heart rate, blood pressure, respiratory rate, and pulse oximetry within the targeted range. Patients with heart failure who exhibit stable vital signs show that they have been able to adjust and plan activities to include rest and allow their bodies to adjust. A decrease in peripheral edema illustrates a reduction in fluid. Avoiding situations that produce stress show a move towards decreased anxiety. And performing and recording daily weight shows adherence to the therapeutic regimen. End of life considerations. Heart failure is chronic and often progressive condition. You need to consider issues related to the end of life and when palliative or hospice care should be considered. So, like we've stated multiple times, heart failure is chronic and progressive. So, a lot of the times it'll be the reason that the patient passes away. So, how does that affect the rest of what they're doing in their life? Are they going to need hospice care? Are they going to need palliative care as they get more ill, as they get closer to the end? So all of that is to be considered. Pulmonary edema. It's acute events resulting in LV failure. What's LV?
Left ventricular.
Thank you. Okay. As left ventricular begins to fail, blood backs up into the pulmonary circulation, causing pulmonary interstitial edema. Results in hypoxemia, often severe, and clinical manifestations are restlessness, anxiety, dyspnea, cool and clammy skin, cyanosis, weak and rapid pulse, a cough, lung congestion, which is moist, noisy respirations, increased sputum production, and the sputum may be frothy and blood tinged, and a decreased level of consciousness. Why are you going to have a decreased level of consciousness?
Reduce oxygen to the brain.
Exactly. Thank you. Okay, easier to prevent than treat. Early recognition, you want to monitor lung sounds and for signs of decreased activity tolerance and increased fluid retention. You need to minimize exertion and stress, oxygen and non-rebreather masks. And then medication would be diuretics like furosemide and vasodilators like nitroglycerin. Management of pulmonary edema is positioning the patient to promote circulation, positioning upright with legs dangling, provide psychological support, so reassure the patient and provide anticipatory care, and monitoring medications and ins and outs. Because when you're giving diuretics, you need to monitor the ins and outs to make sure that you have proper release of fluid. Cardiogenic shock, a life-threatening condition with a high mortality rate. It decreases cardiac output and leads to inadequate tissue perfusion, an indication of shock syndrome. Clinical manifestations are symptoms of heart failure, a shock state, and hypoxemia.
Don't worry about this
Hypoxia.
one too much.
Yeah.
Cardiogenic shock, she said repeatedly, is just not a thing. And even back when I had it before, they always said cardiogenic shock is going, never on like anything.
Okay.
Just know it's a thing.
Management, underlying problems, reduce preload and afterload, decrease cardiac workload, improving oxygenation, restoring tissue perfusion, monitor hemodynamic parameters, monitor fluid status, and adjust medications and therapeutic based on the assessment of the data. Medications, diuretics, circulatory assistive devices. We're going to skip over this because it's not important. Okay, thromboembolism. It's decreased mobility and decreased circulation increase the risk of thromboembolism in patients with cardiac disorders, including those with heart failure. A pulmonary embolism is a blood clot from the leg that moves to obstruct the pulmonary vessels. Signs and symptoms is dyspnea, pleuritic chest pain, tachypnea, and a cough. And then treatments is anticoagulant therapy, unfractioned heparin, low molecular weight heparin, phenoxyprin, and roxaban. Pulmonary embolism. So this is just where you would see it. Okay, pericardial effusion and cardiac tamponade. Pericardial effusion is the accumulation of fluid in the pericardial sac. Cardiac tamponade is the restriction of heart function because of this fluid, resulting in decreased venous return and decreased cardiac output. The clinical manifestations is ill-defined chest pain or fullness, pulses paradoxus, engorged neck veins, labial or low blood pressure, and shortness of breath. Cardial signs of cardiac tamponade is falling systolic blood pressure, narrowing pulse pressure, rising venous pressure, and distant heart sounds. So assessment findings in the cardiac tamponade. Medical management. Pericardial centesis. It's a puncture of the pericardial sac to aspirate pericardial fluid. That is when they stick a giant ass needle into your chest to remove either excess fluid or air to help breathing. Pericardiotomy is under general anesthesia. A portion of the pericardium is excised to permit the exudative pericardial fluid to drain into the lymphatic system. So it's pretty much removing excess fluid. When it comes to general anesthesia, they're going to be intubated. You need informed consent, all of that jazz when it comes to nurse teaching. Sudden cardiac death or cardiac arrest, emergency management, cardiopulmonary resuscitation, ABCD, airway, breathing, circulation, defibrillation for VT and VF. This is we knew the ABCs from last semester. Question, what is the most reliable sign of a cardiac arrest in an adult and child? Decrease in blood pressure, absence of bradycardial pulse, absence of breathing, absence of cardiotide pulse. Cardiac arrest, what are we going to see?
B.
B?
B.
Okay.
The cardiac pulse.
Yeah,
Alright.
yeah.
Yep. The most reliable sign of a cardiac arrest is the absence of a pulse. In an adult or child, the carotid pulse is assessed. In an infant, the bradycardial pulse is assessed. And that's the end of that chapter.
Because the carotid is the brain.
Yep. Awesome. So that went by pretty quickly. Any questions? Anything?
You want to do questions from the textbook, like those practice questions?
Which ones?
The clinical reasoning ones. I don't actually have them here.
No, what's that called? The
Critical thinking exercises.
no, that's practice question from the textbook when you the course point question.
Oh, are you
What?
talking about like the Taylor? I mean,
Yeah.
Oh,
Oh,
prep
wow.
you?
yeah.
Oh, no.
Fuck that. Prep
No.
U's useless, dude. When has
So
Prep
the-
U
the-
ever
the-
helped you?
The
'Cause it
critical
didn't help
thinking
me last
exercises
semester.
a lot.
Prep U never helped
I
me
just
last
don't have
semester.
the.
All
I don't
right,
have
I'm
the
gonna
answers in
stop recording because we've covered everything that we're gonna cover today, other than maybe possibly doing some study questions. We're gonna continue the last two chapters of cardio on Sunday. I do not have an exact time yet. I will let you know when. And also we have a study group for a quiz review. We have our quiz on Thursday. So Wednesday, I will be holding a study group. But if you're coming to that study group, come with questions because I'm not reviewing like I'm doing now. I'm going to answer questions. We're going to have conversations about different topics, and that's how that's going to happen. So that's what is happening in the next week. So let me